Hello everyone, I can see Dr. Kamal, Dr. Nitesh, Dr. Sanjeev Gupta. Hi, how are you? So, I think all of you are already there. Very good afternoon. And somebody joined from two devices in the same room. Please join from one single device from each room. So, I don't see Dr. Mohit. There, Dr. Mohit is there. Very good afternoon, Dr. Mohit. How are you? So, you are on mute. Mohit, you're still on mute. You can unmute yourself.
Yes, sir. Good afternoon, sir.
Very good afternoon. Wonderful seeing you.
कैसे
All
sir?
set?
हाँ sir, एकदम.
Great. He's just waiting for Pradeep and there.
क्या चीज क्या अरे क्यों यार क्या बुलाएगा अरे कुल्लड़ में चाय पिला कुल्लड़ में बस भाई कुल्लड़ में चाय ले चार मलाई मार्केट सुनो सीढ़ियां है सर आप कॉफी करवा देता हूं ना अरे नहीं चाय सर ने चाय बोली तो चाय
लेकिन वीडियो और उसको फिर ऑफ रखना वीडियो और उसको. हेलो तुषार सर.
Yeah, so we are all there. I think, have you already gone live or we are just about to go live? Navneet, are you there with us on this?
Yes, sir, I'm there.
So how much time for us to go live on this focus workshop?
We
I
are
think the
live.
faculty is all there.
Please make it live. I'll make it in 2-5 seconds.
So how many participants are already there, joined in the
Just
workshop?
I'll let you know. Just a minute.
So meanwhile, welcome Dr. Tushar Parekh.
19 participants are there.
Okay.
At time it was 34, but I think they were waiting and now they left. They will again join once we are live, sir.
Okay, so already 34 have tried to come in and more will be coming in, right?
The participants' numbers were quite good.
Yeah, they must have gone for the neurodevelopment. Again, they will come and join now. So we just wanted to delay this workshop a little bit because the neurodevelopment
delegates will join.
They've started joining, right? So this is what I expected, that the people who are there in the neurodevelopment workshop are also very much interested in the point of care ultrasound workshop. So we just, although they could have gone for the recorded version, but we wanted them to be able to join live. So because wo live ka maja alag hai. So we just let it 5-10 minutes here, and I'm sure that most of the people are now joining us rapidly from the neurodevelopment workshop. They are all. It just takes a couple of minutes to come to the virtual platform. Unlike the real conference where it would take much more time walking from one hall to the other. So I was able to go back and join again immediately. And I'm sure, is Dr. Pradeep there with us now?
Yeah, he's getting connected. He's getting connected.
Yeah, so see, Dr. Pradeep is also getting connected very fast. And we have Dr. Saket, Nitesh, I think will be moderating, Tushar, Dr. Kamal Arora, Dr. Sujata, Dr. Deepak, and of course my very good friend Mohit Sani is also already there. So sorry Mohit, we kept you waiting for some time.
No, sir, no issue.
So I think we can go live without wasting any more time. Let's go live and people will continue to trickle in. So Pradeep, I would like you to initiate the talk on the live thing, and then after you I'll come in and we'll ask Dr. Neeraj to introduce all the participants and all. So we'll go that way.
We'll go find out. Neeraj, are you there?
Yeah, Neeraj is already there.
Are there? Okay. Navneet, are we live now? What?
Just a minute, I'll just say okay, and we are live, sir.
Navneet, are you there?
We are live, sir, now.
Okay, we are live, Pradeep. We are live.
I think there is some problem with Dr. Pradeep's internet.
Dr. Pradeep, are you there with us? We are live now. Okay, meanwhile, I'll start. And this point of care ultrasound workshop is the crowd pulling workshop. So if you keep this workshop, point of care ultrasound workshop, in any conference, then this is the biggest crowd puller. Mohit is so charming that people just flock into this workshop and you have to actually restrict entries here. So this is a wonderful workshop and a very important one also. I am glad to share that we have almost 400 participants in a virtual conference, of which almost 300 are the paid participants who have paid, and they wanted to learn from this very important learning event. So I would say it's a mega learning event and made very successful, academically very strong because of the inputs by Dr. Neeraj and the support by Dr. Pradeep, it was basically a three-man team which was doing everything. And the academic sessions and all were being taken care of from Honorary Institute of Medical Sciences, Jodhpur, by Dr. Neeraj Gupta. And single-handedly, he's done a wonderful work in getting all the people together, all the faculties together, and coordinating everything. And Pradeep has been at his beck and call, assisting at every stage, and then talking to people and trying to get the thing is very good, wonderful, but letting it being known to all the other people who are potential participants. So what has happened is that it has spread its wings across Rajasthan, and then it went beyond Rajasthan. It went beyond the state boundaries and went into the country. Then it broke the country boundaries also. So we have international participants also coming in, and this is one measure of the success of the whole program. And the program was designed to make people learn, get them on a platform, and make sure that everybody's got the best learning possible. So I'm glad that we are doing it on the United Nations Day, which is the 24th of October. And it's a memorable day for all of us. The UN came into being, and from there the WHO and UNICEF and all the other bodies of UN came into being. So this is an auspicious day on which we are doing such an important teaching program. And I think for every pediatrician, this becomes very important. And because ultrasound is a new modality, relatively new, and when it started picking up, then it was tarnished by certain acts of parliament and certain restrictions, and then it could not, spread its wings so fast. Otherwise it would have done. But still, the ultrasound machine is there in almost all hospitals. It is there in almost all setups also now, the private setups also, and at many places it has moved inside the NICU and the PICU. So it is not the domain of the radiologist anymore. And the point of care ultrasound basically means that it is just every pediatrician and neonatologist should be able to use it like a thermometer or like a stethoscope. So very soon these gadgets are going to replace the stethoscope. And ultrasound is such a gadget, such a useful gadget. But like all tools, it is upon the person who's handling those tools and his knowledge and his experience which can make the tool better. So today we will try to enrich ourselves, and I welcome all you participants that you've registered for a very important event, and you are going to learn from people who've got experience, people who've been doing it for quite some time, and they have the knowledge as well as the experience and the skill to do it, as well as to teach you, to bring it to you. And I'm sure it will be a great learning opportunity, and you will be glued to your seats. You will not be able to move away from your seats during the entire workshop. So I'm so sure of that. And I hand it over to you, Dr. Pradeep, if you are with us now. Dr. Pradeep, we expecting this. Yeah, Dr. Pradeep, are you there with us?
Yeah, yes. I'm very much there.
Yeah, so
thank you, sir.
Over to Dr.
I know it is going to be most crowd pulling session, as Anurag sir has mentioned, for two reasons. One is, of course, the person in the frame one, Mohit, is a very well-known teacher here in Western India. I'm really fond of and a follower of him. I think last 15 years since he came from, I think Canada. He came from after his initial learning skills. But after that, he has always been a great teacher and a great administrator also, and a great academician also. And one is you, and one is the topic. Of course, it is one of the most sought-for topic by most of us who are into neonatology practice. I think we should not come too much in between. Just few things. Us here who will be supporting you. I'll let you know, and we all will be around so that for smooth functioning of the session. And I think Mohit and all of us have done good practice for last 2-3 days, and I hope this session will go ahead well with the audience too. Neeraj, please.
Thank you, Pradeep sir, and a very good afternoon to all of you. First, I would like to welcome our esteemed faculty members led by Mohit sir and his team, and my delegates. So I think, as rightly pointed out by Pradeep sir and Anurag sir, we started salvaging more and more premature babies. So we started encountering their problems, and it became the need that we cannot call radiologists every time to look at intraventricular hemorrhage or periventricular leukomalacia. So pediatricians or neonatologists, they themselves started doing that and got expertise, and then gradually this modality started moving towards echo, and now I think ultrasound modality is used for each and every organ of the body in one way or the other way. And so, but it is equally important that when we are using this modality, so I believe that whenever we learn something new, we should always simultaneously learn its limitations. That's very important. So this is a tool which should help in taking our decisions in a better way. It is not that we are entirely dependent on this modality, But yes, this modality is important and to a reasonable extent now has become essential if you are running level 3 services to have ultrasound or echo machine in your unit for especially for the babies who are less than 30 weeks. So previously we used to have crowds for ventilation workshops. Now the craze is towards the point of care ultrasounds and echo workshops. So without wasting much time, I invite Mohit sir and his team. So over to you, Mohit sir. Please introduce your team members and so that we can go ahead with it. Thank you very much.
Good evening, everyone. Thank you, Dr. Anurag, Dr. Pradeep, and Dr. Neeraj for organizing this and inviting us. So we during the day, like in next 3 to 4 hours, we will be talking like, it is in the short parts. We will be talking about few things about major things about the heart, head ultrasounds. These are the two things. And then in one lecture, we will just touch that how you can use ultrasounds for putting in the lines and see the tip of the line and then see the ET tip, which can be useful in your day-to-day practice in ICUs. So we have Dr. Tushar Parekh, who is a consultant neonatologist in Pune. And he's been trained in Australia and did his DM from Mumbai, and now he is being practicing in Pune and from the last more than 10 years. And he has been doing this functional echoes and ultrasound, lung ultrasound, and everything from the last 15 years. And we have with us Dr. Kamal Arora. He is a consultant neonatologist at Dayanand Medical College, Ludhiana, and he has done his DM from AIMS. And he is being also now into this from the last 4 or 5 years and into functional echoes, and he has been carrying out in his unit and training his fellows and residents there. And we have in our team today, we have Dr. Pradeep Suryavanshi. He's a bit busy somewhere, so he will be joining later. And he is being well known for his contributions. He's also one of the pioneers, and he's been trained in Australia too. And now he's been running courses and he's doing these echoes and functional point of care ultrasounds in his unit in Pune. So we will start with the views of the heart. What we will do is initially we will discuss, like we will share the slides and we'll discuss the things. And then in the last 5 to 10 minutes, I would show the actual baby where you keep the probes, all we have discussed. So I will summarize and then show it on the baby so that it will be better understood by the people if you see it live, where what we are doing with the machine and with the probe on the live baby. So if I can share the screen.
Yes, go ahead.
Okay. So you can see my screen. Are you able to see my screen? So in the next half an hour or so, we will discuss regarding the basic echocardic views. Okay, and this is basically we will be focusing on the functional, like functional echocardiography is when we think that the heart is anatomically normal. Whenever who is been doing functional echoes thinks that the heart is not anatomically normal, then the first thing we should do is to consult pediatric cardiologist if you have any doubt, because otherwise it will be dangerous and it will be bad for the baby's outcome. And it is an adjunct, like Dr. Pradeep, Dr. Anurag told, like it is something which will be replacing your stethoscope. So yes, it is an adjunct, but it never replaces your clinical knowledge. It is an add-on. So clinically, whatever you have been doing, continue doing that, but it gives you the additional information. So as everybody knows, nowadays, a lot of webinars are being going on. Everything is online. So we show you the videos online, okay? But it is very difficult for the person who shows you the videos to know how the other person has learned it. So then it becomes dangerous if you have learned wrong. If you have any doubts, you can contact the person who has shown online videos and don't get into the trouble. So let's start with the basic views directly. And we will be teaching only very basic views, 4 and 5 views in this time. So one is apical 4-chamber view. Okay, apical 4-chamber, 5-chamber view. This is the first view we start. Most of the people, like adult cardiologists and pediatric cardiologists, they start with the subcostal views. Okay, but in newborns, we tend to do these views in the last, because if your baby is not on ventilator, it irritates your baby and the baby starts crying. And then you don't get the proper windows in the views. So one is apical 4-chamber view. Then we have parasternal views. Parasternal views are low parasternal views and high parasternal views. Low parasternal views we again divide into parasternal long axis, parasternal short axis, and high parasternal views. The main views are ductal view, pulmonary artery view, and suprasternal view, which is also high parasternal view. It is for the arch of aorta. And then we come, in the end, we come to towards the subcostal windows. So it is subcostal views, basically for we see it for the interlateral septum and 2 atrias. Whichever sequence you follow, it all depends upon you. But the only thing is, you have to follow the full sequence, because you have to see each and every part of the heart. And then depending upon on those views, we make assessments. So these are the basic views when we talk about the basic views for functional echocardiography. You may be seeing 100 of machines nowadays, okay? But I tell you, it is not like that if you have got the demo or the training on Philips, and then you go into some unit and you start using G. So it is not impossible. Okay, it just the buttons position and nomenclature of some of those buttons are different, but the basic functionality remains the same. So you should not be worried that the machine is different. Okay, and then we talk about this basic echo screen. This is the basic echo screen. And when we do an echo, we do it with the sectoral probe. There is a phased array probe. So in that, what happens? From pointed end of the probe, I will show you the probe also, how it looks like, the phased array probe. The beams of ultrasound, they fan out like this, so that you can cover more area. Okay, so this is your basic sector. And this one, this V which is being written, it is a probe orientation marker. By convention in cardiology, it is always on the left side of the screen. In radiology, by convention, it is always on the right side of the screen. You can move this probe orientation marker up and down. Normally, apical 4-chamber and 5-chamber views, we take it upright. This is anatomically corrected, because the ventricles are always on the lower side and atrium are always on the upper side. But adult cardiologists, they always do it inverted, like they keep this probe orientation marker up, so the heart is upside down. The ventricles are up and atrials are down. That is the only difference. But all other views, you would see that in many of these views, this probe orientation marker is up. Then we have, ideally, we should be having the ECG tracing leads on for every baby, for every echo study. And this is the image. And for image optimization, the image at least should fill 60% of the whole sector. ये आपका जो सा भी sector है, ये ultrasound का, this sector, it should be 60% filled by the image of the structure you are doing the ultrasound for. Then this is the Doppler scale. If you put on the color, so it gives you the range of the Doppler. It is very important, because that is basically to control and see, like if you are doing the Dopplers of any venous flow, then this range should be dropped down, because this shows the velocity. So the venous system will have a lower velocity. So if you have kept the range of higher velocity, you won't be able to see the flow. And if you bring it very down, and you are doing the Dopplers of aorta, and you bring this range very low, then you will see a lot of turbulence in that. So it has to be appropriate for the structure, for the structure you are doing the echo. So you should be well aware which structure I'm doing the color Dopplers, and I have to change this Doppler scale. And this is the color Doppler field, color Doppler window, as you can see. So what you are seeing is color Doppler is being done across. This is RA, this is RV. So this is your tricuspid valve. So we are doing the color Dopplers across the tricuspid valve. And this is the probe orientation marker. I have already explained that. So there are different buttons on your machine. One is depth button. It is to adjust, like it is something like magnifying. You have to go in and out, like you have to make, when you increase the depth, it means you are bringing the structure which is far off in your sector or in the chest closer to you. Okay, so it is making, because the neonatal heart is very small, so it will bring it up. That's why we use high frequency probes in newborns, because high frequency means the in high frequency probes, what happens is the penetration is less, but resolution is high. So it will make the smaller structure more big, but it will not penetrate much. And anyway, in neonatal, in newborns, the chest width is not much. So we don't need something which is to go and penetrate deep. Then we have this gain button. Gain button is basically to increase and decrease the gain in 2D. In 2D, you see the structures in black and white. So in black and white, when you see the structures, you can increase and decrease to differentiate, because black is fluid and white is the tissue. So you have to differentiate the cardiac, or whenever you're doing the head ultrasound, whichever, that the structures and the tissues should be well differentiated from the blood or any fluid filling in the cavity. And then that similarly, you can increase and decrease the gain of the color Dopplers also. And then we have these different modes, like we do the Dopplers of pulse wave, by continuous wave, and we have this M mode, motion mode, to do to measure various structures in the heart, and we do use it to measure the functions. Okay, and then invert and freeze the image you can store, and all those things you can do. I just want to introduce, like touch around what is the difference between the pulse wave Doppler and continuous wave Doppler. Normally, all the Dopplers in all the vessels are to be measured by this pulse wave Doppler. What happens in pulse wave Doppler? The blood RBCs which are flowing in this sector, only it measures the velocity of those RBCs. It ignores the velocity of the RBCs which are above and below this sector. Okay, so it has a limitation that it cannot measure the velocity more than 2 meters per second. So if you normally the velocity never exceeds 2 meters per second, but if you have some constriction, okay, or you have some coarctation of aorta or something is small, then in that case the velocity will increase. So then you cannot measure with the pulse wave Doppler. If you will try to measure it, you will start seeing the Nyquistic effect. How it looks like, or aliasing, what we call, I will show you in the video. So then you have to shift over to the continuous wave Doppler. So what it does, it measures the velocity of all the RBCs along this sector, and then it gives you the average. That's why the regurgitant flow we tends to measure with the continuous wave Doppler, because if there is a regurgitant flow like in TR jet, we are interested in seeing the gradient of pressure gradient in RV to RA, so that we can estimate pulmonary artery pressures. So that's why we need to have the highest velocity. So if we do it with a pulse wave, we may miss the RBCs with the highest velocity, which are above this sector. So it measures the maximum velocity and gives you the average out of it. So you cannot miss the RBCs with the highest velocity. That's why the regurgitant flows we tend to measure with the continuous wave. So as you can see, we are doing the Dopplers here, okay, and it is within the range. But if I decrease this range, you see this end is broken. So that end, it breaks, it came up. Okay, when we decrease this range, when this range was decreased, this thing tip broken up and came up here. So this is known as aliasing. So this is something like, if you have seen Sholay movie, So in one of the scene when all सब डाकू हेमा मालिनी के पीछे थे, तो वो हेमा मालिनी बोलती है ना धन्नो भाग, तो उस वक्त वो व्हील पे फोकस करते हैं। तो एक स्पीड तक व्हील के स्पोक्स हमको फॉरवर्ड डायरेक्शन में दिखते हैं, लेकिन एक स्पीड के बाद वही व्हील के स्पोक्स हमको ऑपोजिट डायरेक्शन में दिखने शुरू हो जाते हैं। ओके, बिकॉज द स्पीड, द फ्रीक्वेंसी ऑफ दिस स्पोक्स, जो व्हील के स्पोक्स हैं, they exceeds the perception, human perception, so it starts going into the opposite direction, and that is the aliasing effect or Nicotic effect. Okay, and then this is your ultrasound probe. I will show you there with the baby when we will show the practical thing. So this ultrasound probe marker is there. It may be different color or different design in different machines, but it is always there. It always corresponds to the probe orientation marker on the screen. So that's why we never change the site of the probe orientation marker. It stays there. It may change, but to which side it is, that side organs or chambers will come on this side, so that you can correlate the side of the heart. Okay. And when we do the color Dopplers, you see two colors, and it is again by convention, red and blue. Red is the flow moving towards the probe, and blue is the flow moving away from the probe. Okay, and turbulent flows are seen as orange or yellow. So for easy remembering, you can remember the mnemonic BART, blue away, red towards. So now we will discuss the various windows on the baby's chest. So first one is apical window. It is just below the apex of the heart, that is at the 4th or 5th intercostal space, just below the nipple. So that is the apical window for apical 4-chamber and 5-chamber views. And then we have the parasternal views. The parasternal views are again low parasternal views. So that is when you join the nipple line. So around that and below are the low parasternal views, and above that line is the high parasternal views. So low parasternal views are parasternal long axis view and parasternal short axis view. And high parasternal views, or sometimes we also call them subclavicular views. So those are ductal view, suprasternal view, that is the aortic arch view, and then left subclavicular view or pulmonary artery view and pulmonary vein view. And except for this pulmonary artery and pulmonary vein view, there are other views, but we won't talk about that because it will become too much complicated. Okay, so these are high parasternal views, suprasternal view for the aortic arch, and then in the end we have the subcostal view below the Xiphi sternum. So if you have any issues, you can do even all the views of the heart after from the subcostal window. Okay. So okay, it is always good to imagine a clock in front of the baby. So the upper side, this side is 12 o'clock, 6 o'clock, 3 o'clock, and right side, this side is 9 o'clock. So wherever you keep a probe and where the probe marker will be there, we will always talk in terms of time in clock, where the clock, these hands of the clock are. So, okay, and this is just to show you that the various machine has got various buttons, and there are 3 basic views we normally see, and one is this 2D views, okay, in which you see black and white, okay, black and white, and then you have the color Dopplers. In black and white view, what we tend to see, what is the orientation of the heart, okay, how are the structures, if there is any anatomical issues are there, and relative sizes, because if you have a hemodynamically significant PDA, you will have large LA and LV. If you have very high pulmonary pressures, you will have dilated RARV. Okay, so just by seeing a apical 4-chamber 2D view, you will make the judgment, okay, these are enlarged chambers, so this may be an issue. And then you put in the Dopplers, you see the color as we have discussed, red and blue. So we do the blood flow of the blood across the walls, outflow tracts, and if there is any septal like VSD or ASD septal defect, the flow of the blood across those defects. And then we have M mode to measure the size or the contractility of the left ventricle mainly. Okay, we will start with the apical 4-chamber and 5-chamber view. Okay, in next few of the slides, you tend to concentrate first where the probe is being kept, and that will be in your screen on the upper left side of the screen. And then lower right side, you will see how the video will look like, and then there will be a picture with the labeling of the various structures. And as I told, these are the things we can judge, like how much dilated the ventricles are, or how much the blood volume is there, or is there any fluid collection around the heart or not. So you can see this. In this, the probe pointer is pointing at 2 to 3 o'clock position towards the left, is being kept at just below the apex. 15-20 minute के बाद चाहिए होगा. Okay, and this is what you will see, apical 4-chamber view. Okay, this thing. So in this is how these are the labeled. In that video you have seen, this is LA, LV, RA, RV. This is interventricular septum, and this is interatrial septum. These are the pulmonary veins. This is tricuspid valve. This is mitral valve. As you saw in this, the pointer was being kept on left side, 2 to 3 o'clock position. That's why this thing corresponds with the pointer. That's why it is LA and LV. There are other ways, anatomical significant markers are there, how we can identify LV and RV. But you know, it is something very advanced, and it comes into the structural studies. So, and then what we do is, if we rotate this pointer for 2 to 3 o'clock position and sweep, as you can see, we are sweeping the pointer upwards. So what we are doing is, we are going anteriorly towards the heart like this, and hence it gives you the apical 5-chamber view. So that is your LA, LV, RA, RV, and this aorta opens up because aorta will be anterior to your LV. So that's why we call it apical 5-chamber view. So this is apical 4-chamber and 5-chamber view in 2D. Okay, this is just to show you that how this beam of ultrasound, it cuts your heart. Okay, it cuts your heart, and then from in between, okay, from apex to base, and it gives you that picture in front of you. This is how the heart is being cut by your ultrasound beam. It is something like this. Apple is being cut like this and shown in front of your screen. And when we put on the color, we see the flow across the tricuspid valve, mitral valve, and then through major vessels like aorta, we have seen in apical 5-chamber view. Therefore, we can calculate our cardiac output. But it is a caution, if you see any ventricular septal defect and blood flowing through that defect, whenever the flow of the blood is left to right, it will be, the situation is such, it will be towards the probe. So it will be left to right flows will be red, and right to left flows in ASD, VSD, and PDA will be blue. And if there is a bidirectional flow, you will see red and blue. Okay, but never try to calculate the size of VSD or the flow across this VSD or ASD in this apical 4-chamber and 5-chamber views, because they are perpendicular to the flow is perpendicular to the direction of the ultrasound beam, which is against the basic principles of ultrasound. Okay, so and the size, again, we cannot do, because that is in line with the ultrasound machine. It has if you want to calculate the size, then that structure has to be perpendicular to the beam. And if you want to calculate the Dopplers, that flow of the blood should be in line with the direction of the beam. So that's why we don't calculate the size of VSD or ASD or measure the Dopplers in this view. Okay, this is how when we put the Dopplers across the tricuspid valve and mitral valve. So this is across the mitral valve. Okay, you can see we put the color window, and this is how the color Dopplers we will get. And this is across the apical 5-chamber view through aorta. We calculate this VTI here in this aorta here by putting the pulse wave Doppler. This is how you will see the VTI, that is velocity time integral. And this helps us in calculating the cardiac output. outputs. And then if we further sweep up, so that aorta, which was like this, it is gone. And now you see this again, another vessel, which is just across the aorta. Aorta is gone. So that is because this is the crisscrossing of pulmonary artery and aorta. They are at right angle to each other. Okay. So therefore, it rules out our very big anomaly, that is TGA, transposition of great arteries. Because if there is a TGA, they will be in same plane. But normally, aorta and pulmonary artery are in different plane and at right angle to each other. With this sweep in apical 4-chamber and 5-chamber, we tend to rule out that. Okay. And then the next view is low parasternal views. So that is parasternal long axis view. In this, it tends to cut the heart longitudinally. Okay. And we have two sweeps in this. One sweep is upward, that is pulmonary artery sweep. Another sweep is downward, that is tricuspid valve sweep. In this view, we can do the Dopplers for the VSD if the VSD is there. And in M mode, we do the cardiac contractility. So you can see in this, the pointer is being placed at 11 o'clock position towards the right shoulder at the nipple line. Okay. And then this is what you will see. And in this, you can notice that your marker is up now, above. And these are the structures you will see. This is anterior wall of RV, right ventricle, interventricular septum, left ventricle. This is mitral valve. This is aorta, aortic valve, and LA. So what is happening is, it is cutting. So this is what is happening is 11 o'clock. So this is when your patient will lie down. This is how it will cut the heart. It's cut longitudinally. So this is your RV, aorta, LV, and this is mitral valve. This is how it will be cutting the heart. So it is something like banana split ice cream. It will cut the heart longitudinally like this. And when you put on the color, this is how you will see. So if you have a VSD, then you will have a flow across this interventricular septum. If it is left to right, so see, this is towards the probe, it will be red. If it is right to left, it will be away from the probe. That's why it will be blue. In this view, you can calculate the size of the VSD. And then we do M mode in this to calculate the FS, that is fraction shortening for contractility of the heart. In this view, in this video, you will see how this sweep up and down is been done to look at the pulmonary artery and aorta and tricuspid valve. So this is this view. This one is your basic plaques view. This is your basic plaques view. If you do it sweep downwards, you will see tricuspid this tricuspid valve. And then if it is swept upwards, once you get it upward, this aorta which was there, it will gone, and you will see a vertical vessel from upside down coming down the pulmonary artery. This again rules out your TGA. Okay, see, this is how you are doing. If you sweep upwards, this is what the pulmonary artery comes down. And this is your aorta which is gone. And then if you put a color, you see this. If you put a color, this is a main pulmonary artery, this is your RPA, and this is your LPA. And then if you sweep it downwards in that same position, you start seeing that tricuspid valve. And this is a good view to calculate your TR jets. The blue color will be, this blue color will be TR jet because it is away from the probe. Then in the low parasternal views, the other part is the short axis. In this, what we'll be doing, we will be cutting the heart in cross section. In long axis, we were cutting in longitudinally. And now in this, we will be cutting the heart in cross section. Okay. So in this, we start from the base of the heart, that is from where the aorta is originating. Okay. And then we sweep towards the apex. So we will start from the aorta, base of the heart. We'll go towards the mitral valve. Then in left ventricle, we will see the papillary muscle, and then the apex, which is apex forming chamber. It is important because if you have hypoplastic left heart, then your right ventricle will be apex forming chamber. Again, in this view, you can calculate the size and the flow through the VSDs. And again, in M mode, you can do the contractility. So as you will see in this, you can notice this is the pointer, which was facing at 11 o'clock position, is now is been rotated at 90 degree, is facing at 1 o'clock position, at the same position at the nipple line. Okay, and this is what you will see. Okay, and this is because of this is aorta, and the aorta has got 3 valves. Because of this, it is known as Mercedes-Benz view. So you have aorta in cross section, RV, tricuspid valve, RA, interatrial septum, LA, and these are the coronary arteries, and this is the pulmonary valve. This is right outflow tract. So in this view, you can see this view, which was being taken, in the apical 4-chamber view. Now you can see the heart was cut from apex to the base, and now in this you saw that the heart is being cut cross-sectionally. So this is how the heart is being cut. So this is how you cut it at the base. And hence, here you will see aorta in the cross-section like Mercedes-Benz sign. And this is the sweep you do from the base of the heart towards the apex. So here you will see aorta, here you will see mitral valve, papillary muscles, and then the apex. So it is something like the apple or banana is being cut cross-section like this. So here you start with the base, okay, and you sweep it downwards towards the apex. The first thing you will see, next thing after the aorta, the Mercedes-Benz view, you will see this mitral valve view, which is also known as fish mouth view. Okay, this is again IVS, RV, LV, and this is interventricular septum. And then if you sweep further down, you will see this papillary muscle view. Again, the LV is there, but that papillary muscles you are seeing now. These are the papillary muscles. And then you sweep it further down to see which is the apex forming chamber. And as you can see, the RV goes away, and what is being left in the end is the apex, which is being formed by LV. So it rules out your hypoplastic left heart. And then you can put in the colors to see whether there is any interventricular septal defect or not. So those were the low parasternal views. So, and these are the high parasternal views, that is in the upper 1/3 of the sternum, or we also call them subclavicular views. So a ductal view, which is mostly in the subclavicular view, pulmonary artery view, pulmonary vein view. This is a specialized view. I will not be talking about that. Then suprasternal notch view, that is aortic arch view. And then we do it again. This is a specialized view. I will not be talking about that. So ductal view, ideally it has to be done on the left subclavicular window when the pointer is pointing at 12 to 1 o'clock position. But in newborns, in preterms, it can be done from the right side also. It is better. Sometimes you see better the ascending aorta better in that. So this is how it is being done and kept. You see the probe 12 o'clock to 1 o'clock position, right subclavicular place. And this is what you will see. It is a kind of modified short axis view. So what you will see is aortic valve. This is your right ventricle, pulmonary artery, RPA, LPA, and this is the descending aorta. Because PDA always arises from descending aorta and goes into the pulmonary artery from the LPA side. Okay, and this is how when you put on the color. So when you put on the color, you see there were 2 blues in this, and there is no connection. But you see in this descending aorta blue and the pulmonary artery blue, you see a red jet. This is what is PDA. And it is from aorta towards pulmonary artery, that is left to right towards the probe. That's why it is red. If it is bidirection, then you will see in some frames it will be red, in some frames it will be blue. And if it is pure right to left, then you will again see this PDA flow will be purely blue. And that's if you are doing it, you are the starter, you tend to miss the PDA in the color Dopplers. And this is your aortic arch view. This is the suprasternal notch. Again, the pointer is at 12 to 1 o'clock position. Okay. And this is what you will see in aortic arch view. This is your ascending aorta. This is arch of aorta. These are the 3 branches. And this is a descending aorta. And you have this RPA. Why it is like that? Because when aorta revolves, this is the pulmonary artery, aorta revolves like that. So if you have cut the aorta in longitudinally, then you see cross-sectional view of RPA because they are at right angle to each other. And when you put on the color, this is how you will see the color in the aorta. From up and down, it is blue because it is away from the probe. And then you can do the Dopplers in that, and you can calculate your velocity time integral and velocity of the blood in aorta. So then you have pulmonary artery view and pulmonary vein view. This is again in left subclavicular views. Okay. So you see in this, the probe is on the left side, but the pointer is pointing towards the 3 o'clock position. Okay. It is not 12 to 1 o'clock position. It is in 3 o'clock position. And then you will see this. This is the cross section of aorta. This is the MPA, main pulmonary artery, right pulmonary artery, left pulmonary artery. It is also known as the pent leg view. And then you put in the color in this. In color, you can see. So in this view also, you can see a PDA entering into your pulmonary arteries. And similarly, in the same place, a 3 o'clock position probe marker, you have to sweep the probe downwards. In pulmonary artery view, you have to sweep it downwards. If you sweep it downwards, this is what you will see. This is your LA, and these are the 4 pulmonary veins coming into your LA. So if you put on the color, this is what you will see. 1, 2, red. 2 pulmonary veins which are towards the probe will be red, and the other 2 which is from upside down will be blue. And this view is known as the crab view. And then comes the subcostal views. In subcostal views, the probe is to be kept just below the xiphisternum or upper 1/3 of the line joining xiphisternum and the umbilicus. And there are 2 types of subcostal views. One is cross-sectional view, when the pointer is pointing at 3 o'clock position. Another are longitudinal views. The pointer is pointing at 12 to 1 o'clock position. And now this is what you will see. So you will see 2 atria. This is LA, RA. Again, you will see this probe orientation marker is down. This is what I personally do for myself, because whenever we see a heart, if we think this is your eye and you are in subcostal region, the chamber which is nearer to you is LA, RA, and away chamber is LA. So if you keep it up, it will be inverted. Just to correct it anatomically, I do like this. So this is your LA, RA, interatrial septum, tricuspid valve. These 2 are the pulmonary arteries. And then you have PF4 ASD. Isko nipple or wo de do na koi. When you put on the color, so you can see the color moving across the atrial septum. And this is again, if you just keep it here and sweep upwards, you will see SVC entering in your RA. And then you can do the pulse wave Dopplers. This is how the SVC Dopplers. It is again to know the SVC flow, and it gives you the indirectly the cardiac outputs. Okay. And these are the longitudinal sections of subcostal views. Here the pointer is pointing at 12 to 1 o'clock position. If we sweep this probe towards the right side, you will see IVC entering into your RA, and this is your hepatic vein. And if you sweep this towards the left side, you will start seeing the spine, abdominal aorta, and these 2 are the celiac trunk and SMA. So these are the longitudinal abdominal views. Okay. So in the end, see, we will be discussing ductal pulmonary hypertension and systemic perfusion means shock, because of these three things are most common. And this table gives you like in which 4-chamber, 5-chamber, long axis parasternal, short axis parasternal, ductal view, arch view, subcostal view, what all parameters you will do. So at the end of the workshop, this will be much more meaningful for you. Okay, and these are the reading materials or the books from you can order this on this number and you can get the books. It has been done like this contains the head ultrasound, abdominal ultrasound, echo and everything, and this contains only the echo. So thank you very much for seeing this. In next just 5 minutes, I will just quickly show you the how the probe we put on the baby's chest, so that you will be able to see how it is being seen on the live baby within. So this will be a live video, and one of my colleague, Dr. Kunj, will be doing this video. He is already there in this group, I think so. Yes, he is there. So he will be doing that. So you can please, we will unmute Kunj, and you can put your option on your screen on speaker's view. Once you will put it on the speaker's view, you will be able to see the his whole video on the full screen.
Horizontal. Start. So, so this is the probe. Udhar speakers. Sorry. So, my friends, this is the probe, and this is what we call as phased array probe. As you can see, this is rectangular. Okay, this is a cardiac probe. This is 12 hertz, and this is the marker in this. This is the marker. Okay, and when you see it on the screen, okay, so this is you can see this is. So this is your probe orientation marker. As you can see, it is on the left side. I can move it up, I can move it down. And this is the whole sector. Okay. So there are various buttons on the machine for the depth. For the depth, for the gain, 2D, color, pulse wave, continuous wave. Okay. So these are the basic things. I have already done the pre-settings. This is for premature babies. So if your baby is less than 1.5 to 2 kg, you have to have one settings. If your baby is term, then you have to have the term settings. This is how I'm holding my probe. Okay. So then you have to apply the gel on this probe. When you apply the gel, this is how it will look on the screen. This is how it will look on the screen. And now, for a Pical 4-chamber and 5-chamber, I will be putting this probe orientation marker on this is a nipple, just below the nipple. Okay, and the pointer is pointing at 2 to 3 o'clock position, or the left side of the probe, left side of the body. Okay, and this is what you will see. I'll just take a minute. So you see, this is how if you decrease the gain, it will just go down. And you have to bring it up. Okay, then you have to adjust the gain. Once you will adjust the gain, this is how the apical 4-chamber you will look like. Okay, and then if I sweep this probe bit up, I will start getting this iota here. So this is your apical 5-chamber, 4-chamber and 5-chamber. If I put a color, I will see this aortic flow here. This is apical 4-chamber, 5-chamber. Okay. Now for parasternal long axis, this pointer, now we have to do parasternal long axis, that is a low parasternal view. So this is a nipple line. Okay. And then I will keep with this jelly, I will keep this probe orientation marker towards the right shoulder at 11 o'clock position at the nipple line. Okay, and this is how you will start seeing your basic parasternal view. So in basic parasternal view, this is your anterior, this is your probe marker of anterior right ventricular wall, RV, interventricular septum. This is your LV, this is your aorta, this is your mitral valve, and this is your LA. Okay, so this is your standard plaques view. If I sweep it up, okay, same way. If I sweep like this, sweep up, you see this, that the aorta which was seen here, if I sweep up, is gone, and you start getting this pulmonary artery here. Okay, so this is pulmonary artery sweep. Then again I come to the standard plaques view, and if I sweep downwards towards the foot, now you see this is your normal standard plaques view. If I sweep down, you start getting this tricuspid valve here. So this is your tricuspid valve. So this is plaques view. Sweep up is pulmonary artery sweep. Sweep down is tricuspid valve. Okay. Now, if I rotate this probe from your 11 o'clock position towards the left shoulder 1 o'clock position in the same place, it will be parasternal short axis. So you start with the basic one from the base. As you can see this 3 valves. So this is your Mercedes-Benz view. This is your pulmonary artery, pulmonary valve. This is your RP, LPA. So this is your parasternal short axis with basic view. Start from Mercedes-Benz view, and when you sweep it downwards towards the apex like this is how the changes you will see. From base view, you come down to this fish mouth view. This is mitral valve view. And when you sweep further, this is your papillary muscle view. Fish mouth view, and then you have these papillary muscles here. So that is a papillary muscle view. And when you sweep it down further, this is your apex. You can see the apex from the RV is gone, apex from the chamber is L. So that is parasternal short axis. And now we go for high parasternal views, and one is ductal view. So we can, in newborns preterm, we can combine this. The pointer is pointing at 12 to 1 o'clock position here, and on the sub or left clavicular area. When we do that, this is what you will see. You start seeing the this ascending aorta, arch of aorta. These are the branches, and this is the descending aorta. So the whole aorta you will see. So this is aortic arch view. When we put on the color, you can see very nice laminar flow in the descending aorta, and this is your RP. So if I go towards 12 to 1 o'clock position, same towards the left infraclavicular area, this is your ductal view. So here you can see this is your main pulmonary artery, this is your LPA, and this is your descending aorta. So if I put a color, and if there is a PDA, it will be red if it is left to right, and if it is right to left, it is blue. And as you can see, there are two vessels with blue color, no red. So there, this is MPA, this is your descending aorta, but there is no connection in between. So there is no PDA. Similarly, now, if it's from 12 to 1 o'clock position, if I rotate this probe for the 3 o'clock position, so now this probe is at 3 o'clock position in the same infraclavicular left area. This is what you will see on the screen. You are seeing aorta in cross section, and then span. And then you have this MPA, LPA, and RPA. MPA, LPA, RA. And then in the similar place, when you keep it there and sweep it down sweep the probe downwards toward the foot, you will start seeing your LA. Start seeing your LA. Pulmonary veins entering. And now you have to bring down the scale because I'm looking for venous flow. So these things you can very well see. Three. These are the two lower pulmonary veins, and this is upper vein. I can see three veins very nicely entering into my LA. So this is pulmonary vein. And then we go to the short subcostal veins. So come from Jelly. And now I will bring this probe orientation marker down. Okay, cross-sectional abdominal view. The pointer is pointing at, it is sub-ziphoid. Pointer is pointing at 3 o'clock position. And you can very nicely see this RA, LA, interatrial septum. These are the pulmonary veins entering into the LA. If I put a color, again I have to come down on the scale, and very nicely you will see from PFO it is bidirectional flow. It's now blue. That means red to right to left. And in one frame now you see it is red left to right. So it's a bidirectional flow from PFO. And for longitudinal view, again it will go up. So this pointer is now pointing at 12 to 1 o'clock position. And you see, if you sweep it towards the right side, okay, you will start seeing this IVC is there. Start seeing this IVC entering into your RA. And if you sweep it towards the left side, you will see on the screen that this is what you will see. Spine, abdominal aorta, and these two are the CA and SL. So these are the subcostal views. So that completes our whole views of apical 4-chamber, 5-chamber, parasternal long axis, parasternal short axis, aortic arch view, ductal view, pulmonary artery view, pulmonary vein view, and subcostally longitudinal and cross section.
मैं स्टॉप कर देता हूँ.
So this completes our stop. So this completes our cardiac basic views. So the next lecture will be there by, please, Dr. Neeraj, you can take over, please. So the next lecture actually will be by Dr. Kamal Arora, and this will be regarding your PPHN related views. So basic parameters, what basically we need to measure and how we look for significant PPHN. Dr. Kamal. Dr. Kamal.
Sir, just a minute. Just a minute. I'm starting the video. Am I?
Yeah, you are audible and you are visible.
Okay, sir. I will share the screen. It's very difficult to take a lecture after your lecture.
क्यों मैं इतना तंग कर देता हूँ क्या?
आपने इतना समझा देते हो कि हमें लगता है हमें समझ फिर से आने लगे. Listening as मुझे दोबारा से सारा lecture हो गया. Even though I have done it so many times, still I feel that I have learned again. I have learned again.
We all keep on learning.
Thanks for being my teacher always since my AIMS days. And if everybody is listening, sir only taught, Dr. Mohit only taught me in AIMS also. Am I right, sir? I think everybody in AIMS also learned from you only.
Yeah. Thank you very much.
That is really commendable from your side. And still we are learning. फिर से एक नया चीज आ जाती है कि ये क्रैब व्यू कौन सा है फिर से याद आ जाता है, क्रैब व्यू यही होता है, नहीं तो याद. So because I think we are sticking to the basics only, sir, not to the advanced one.
Yes, not
So,
to the advanced ones. Yes.
So the basics, we'll continue with the sir's basics only, Dr. Mohit's basics only. We are talking about persistent pulmonary hypertension. I think I'll just have a bit of it in the physiology part, and then we can go to the echocardiography part. Otherwise, it's very difficult to learn only echocardiography directly from it. So any questions you can send in the chat section. So we'll continue with the sir lecture only. I'm saying again and again because it's a basic one. So what is persistent pulmonary hypertension in newborn? So a fetus has something pulmonary hypertension which is normal, but if it is persistent in the newborn period, it is abnormal. So that's what word PPHN means. I think we all know about it. So I'm starting with one case discussion. We have a term baby appropriate for gestational age, 38 weeks, 2.860, female baby born outside, not in our unit, by LSCS, indication of which was meconium St. Leica, and cry was immediate. But after 20 hours, they noticed that the baby had some respiratory distress going on, and the baby was referred to our unit. At 20 hours of life, baby had increased rates of breathing, and there was bluish discoloration of the body. There was no significant antenatal history, just MSL was a positive history in this case. There were all regular antenatal visits, no medical history. As the baby was received in the emergency section, so they did a pediatric assessment, PAT triangle, appearance of normal, work of breathing as abnormal, skin circulation abnormal. That was done by the junior resident in the emergency. Heart rate was 188. The temperature was slightly on the higher side. Respiratory rate was 102. There was audible grunt also, and respiratory distress was present. Saturation was 78% on room air, and CFT was 4 to 5 seconds. Peripheral was blue. So our assessment is cardiorespiratory failure. As a routine, we did the X-ray and the blood gases along with the CBC. This is a blood gas, the pH of which was 7.14. Lactate was 3.7. Bicarb was 14.3. CO2 was 47. O2 was 34. And base excess was -13. So we had a hypoxia with metabolic acidosis with high lactate. The CRP showed 22.8, slightly on the higher side. Platelets were normal. TLC was slightly higher side, but so there was a component of sepsis also along with this. And because MSL can also cause an increase in CRP, so it was plus minus, but we started with the antibiotics in this baby. X-ray was depicting meconium aspiration syndrome, and we had to intubate the baby as baby was not maintaining. So there's an ET tube in situ, and we can see X-rays, meconium aspiration syndrome plus minus maybe congenital pneumonia, so always a confusion. But as a history of MSL was there, so we kept the possibility of meconium aspiration syndrome. We did an echo for this baby in the emergency only. We got an IVC. The baby was mind that the baby was 20 hours of life. The IVC was full. There was a bidirectional shunt across the PFO. PDA showed right to left shunt. The baby was 20 hours. Again, I'm speaking again and again. There was tricuspid regurgitation was present, and right ventricle systolic pressure was high, 95. So we'll discuss what this functional echocardiography means in this case. Before I go to the functional echocardiography, we have a diagnosis of term AGM, meconium aspiration syndrome, PPHN, query, maybe early onset sepsis. Before I go to the PPHN echocardiography, let's discuss the physiology, because if we know the physiology and the anatomy in the fetal, we can always calculate the measurements, which we'll be going to do now in echocardiography. So a placenta is an organ of gas exchange. In the newborn, the lung is organ of gas exchange. Very clear. There is suprasystemic pulmonary vascular pressures in the fetus period, and which is normal. That's what I started with. Persistent pulmonary hypertension. But in newborn, the pulmonary vascular pressure has to decrease. And the normal pulmonary vascular pressure, which our books write, is more than 25 is abnormal. The pulmonary blood flow is low, less than 10%, and pulmonary blood flow increases in the newborn period. There is low oxygen consumption, and there is high oxygen consumption in the newborn period. The blood flow is from right to left via the ductus and the foramen veil. So now we'll discuss about these two things also in the echocardiography. The blood flow is right to left via the ductus and the foramen veil. So there will be a shunting which will happen from the right to left in the ductus arteriosus, that is PDA, and the foramen veil. Fine. And in the newborn period, they have to close. But if they persist and the shunt persists from right to left, it means the fetal physiology is still persisting. So PPHN results due to the failure to decrease the pulmonary vascular resistance, causing the right to left shunting across the ductus arteriosus and foramen veil. Increase the right ventricular afterload leads to displacement of the septum to the left ventricle and impair the filling. This all leads to the hypoxemia and multi-organ failure. We all know this. Hypoxia is normal in fetus, but not in the newborn. Symptoms can vary from mild respiratory distress to as requiring an advanced ICU care, like in this baby. It started off very well. Baby had just MSL, mild distress, but baby ultimately ended up with respiratory failure. Clinical features, we all know: cyanosis, respiratory distress, hypoxia, out of proportion lung disease, prominent precordial impulse. There's a difference between the preductal and the postductal oxygen saturation, because I'm not going to the detail of PPHN. But why I'm making this clear is because we have to read the echocardiography now. There's a murmur of the tricuspid regurgitation. The murmur is due to the TR. Okay, now coming to the main thing. I think we are very clear what we are dealing with now. Persistent pulmonary hypertension in newborn. So whenever you start with the echocardiography, as Dr. Mohit sir has told, main basic views has to be very clear in your mind. Once your views are clear, we have to make sure that the heart is structurally normal. So you have a short axis view, you have apical four chamber view, you have a long axis view. All the views have to be done, and it has to be made sure that we are not dealing with any congenital heart disease. The heart has to be structurally normal. Otherwise, we cannot label the PPHN as a diagnosis. That is the rule number one. So I've written at the end, remember, need to rule out the TAPVC, which is the main thing which looks exactly like a PPHN. Because in TAPVC, the shunt will be right to left at the foramen veil. So if the shunt is right to left at the foramen veil, you will see, oh, this is PPHN. But actually, this is total anomalous pulmonary venous connection. So in the crab view, which I was mentioning with Dr. Mohit, if there is, you can see the pulmonary veins open into the left, not in the right. So it has to be made very clear. Then you have to rule out the coarctation of aorta. And the third, you have to rule out the transposition of great arteries, the TGA. Hope I am clear in this. Okay. Then once you have ruled out that the heart is structurally normal, that everything is fine, and the clinical course is exactly like a PPHN, so we have to measure the pulmonary pressures now. We cannot directly measure the pulmonary pressure. We have to have the markers for it. So the first, next slide will tell us that. Then what is the direction of the ductal and the arterial shunt? So what is the direction of the ductal and the arterial shunt? If the shunt is right to left, so we are dealing again with the PPHN if we have ruled out that the heart is structurally normal. So how do you measure the pulmonary artery pressure? We measure indirectly through the tricuspid valve regurgitation. We see the peak velocity in the tricuspid valve. That is one. Second, we see the flow through ductus, and we see what is the velocity and the direction of it. We see the flow through the patent foramen veil. We see the right ventricle systolic time interval. That line is slightly difficult to absorb. Right ventricular systolic time interval will come. We'll have 2 or 3 slides on this. Then we see the shape and the motion of the interventricular septal wall. So if the pressure is more on the right side, the septum will deviate towards the left. So that's a simple thing, just that it tells you that there is a PPHN. So coming to the first line, the mean arterial pulmonary pressure. You have to measure the mean arterial pulmonary pressure. The mean arterial pulmonary pressure in a normal newborn has to be less than 25. Anything more than 25 is labeled as that the pulmonary arterial hypertension is there. I think that is by the at the World Symposium of Pulmonary Hypertension in California. That was clearly said, no 35, no 30, no 45. For a newborn, you have to keep any age group, you have to have more than 25 if you want to label as the increased pulmonary pressure. That was, I think, in 2008. Yes, the book writes 2008. Okay. So once you know the peak velocity in the tricuspid valve, the tricuspid regurgitation jet, you have a velocity of, I have written an example like 3.99. You apply a Bernoulli's theorem. Nowadays, all of the machines give you the directly the gradient. So you have a slide that P is equal to 4 V square. That's the Bernoulli's equation. P is a pressure gradient. V is the velocity. So if you want to calculate the pressure gradient, you should know the velocity. So 4 into V square. So pressure, pulmonary artery pressure is 4 into the tricuspid jet velocity square plus some amount of right atrial pressure has to be added into it, like 5 to 10 millimeter of mercury is added to it. So example writes, tricuspid jet velocity is like 3.99 meter per second. We'll in the next slide we'll tell you how to calculate it, but you should know what you are actually going to see. So it is tricuspid jet velocity is 3.99 meter per second second. So pressure gradient would be 4 into V square, 3.99 into 3.99. So that is 62 millimeter of mercury. Adding 5 for the right atrial pressure to it, you get 67 millimeter of mercury as the total right ventricular systolic pressure. So that's the total pressure is 67. So what happens is you are dealing with 67 millimeter of mercury is a pressure. You have to decrease it to less than 25 to say that the baby is improving and the baby doesn't have a PPHN. So you will add Meyer's. The most important pulmonary vasodilator is the oxygen. So first is oxygen. Second, you can go for sildenafil, you can go for inodilators. You have to maintain the metabolic acidosis milieu. So the metabolic acidosis has to go off. The sepsis has to go off. So that's all the management principles of PPHN. So how to calculate is the most of the machines will give you directly like, okay, I'm going to the next slide. You have to measure the tricuspid regurgitation in the apical 4-chamber view. As Dr. Mohit has already told, you have to keep the heart straight. The heart has to be straight. It has not to be angled. Angle nahi hona chahiye. So apical 4-chamber view, you put the gradient over here. First a color gradient, you see a blue jet because blue is away, red is towards BART. That mnemonic, you should remember BART. So you will get a blue jet over here. Put a continuous wave Doppler, not the pulse wave Doppler, the continuous wave Doppler. Otherwise, you will have a effect which, again, Dr. Mohita told you is the जो धन्नो भागने वाला घोड़े वाला बताया था उन्होंने कि they focus on the wheel, वो उल्टा घूमने लग जाएगा, aliasing. So don't apply a pulsed wave Doppler here, apply a continuous wave Doppler here. And the Doppler signal must be complete and you have to measure the downward direction of the tricuspid regurgitation tracing. So now see this slide. You can see the pressure gradient is calculated as 94.9 millimeter of mercury. So the pressure gradient is very high. See on the upper section, I think, and you will be able to see this cursor or not, but the gate has been applied as a, not this one, but as a diamond shape. And just at the blue point, you put a continuous wave Doppler. You get a tracing which is the negative like this. Take the highest tracing and a complete tracing on the lower side, and you see the pressure gradient is already calculated there, 94.9 millimeter of mercury. So this is suggestive of severe PPHN for the same baby. We did this. That baby who was referred to us had a PDA and showed that there was a left to right shunt in the PDA, but PPHN was severe, and this was day 1 of life. So we started measuring this baby on day 2, day 3. And the baby was ventilated, as I already told you. So in repeat echo on day 3, we added sildenafil also, falling pressure of tricuspid jet, and now the pressure gradient was 28 millimeter of mercury. So echo guided us actually that we are improving. We had to start this sildenafil. Clinically, baby looked like, but we were not very sure what is happening with the baby. Fine. Am I clear with the tricuspid valve regurgitation jet? Take the apical 4-chamber view, put a color Doppler there, put a continuous wave Doppler there, see the blue jet is fully covered. Then you will see a negative tracing. Measure the tracing at the most downward point. It has to be complete, and measure the pressure gradient. So you get the velocity. If you don't have a pressure gradient in the machine, all of the machines gives you the pressure gradient. But if you don't get, just measure the velocity 4 V square is the velocity plus 5 to 10 millimeter for the right atrial pressure. You get the right ventricular systolic pressure. That's the pulmonary artery pressure. Okay, you can see in this slide also. This was our previous slide. So you can see a blue jet in the second slide, and you put a Doppler, full envelope of the Doppler is there, and you get a pressure gradient of 43.9. So that's another question. Okay. Then that was the first point. Tricuspid jet velocity, that is regurgitation jet velocity, has to measure PR jet velocity, and then you get the pulmonary pressures. Okay, second point, the way we measure is the shunt through the ASD or the PDA, because these are both the shunts which are present in the fetal period. Now they should not be present in the newborn period. But if they're present and the shunt is bidirectional, or if it is right to left, usually the shunts are bidirectional here, bidirectional or right to left, you think on the terms of PPHN. But again, the caveat is you have to rule out obstructive TAPVC. Heart has to be structurally normal. If it is a pure right to left, think again and again that it could be a TAPVC rather than the PPHN. Okay, so you can see the shunt across the ASD. This is the right atrium, this is the left atrium, right atrium, left atrium. You put a colored Doppler here. You see the flow is there's a blue color, blue away, red towards. There's a blue color. You're getting away from the right atrium, and you put a pulse Doppler. You get a bidirectional shunt over there. Okay, so then we see the ductal flow. That's the same thing, almost same thing. So this is a diagram which shows that if the pressures, the blue color, the pressures go above, the pulmonary pressure grow above the systemic pressures, you can see how the echocardiography changes from a positive to bidirectional to almost negative trace. You can see this 1, 2, and 3. Last part is the positive flow, a positive and negative bidirectional flow. As the systemic pressure keeps on, as the pulmonary pressure keeps on increasing, the shunt becomes more and more towards the right to left. I hope we are clear with this. So now, how we know that the shunt is blue and the shunt is more towards the right to left. So now what to do about this shunt? You will ask about the calculation. So what happens is, when aortic and pulmonary pressures are equal, when aortic and the pulmonary pressure are equal, the flow is bidirectional. Right to left in the systole and the left to right in the diastole. So during cardiac cycle in PPHN, a jet of blood moves between the main pulmonary artery and the descending aorta. So by measuring the velocity of jet, the pressure gradient can be calculated. Again, the funda remains the same, the Bernoulli's. So for example, if the velocity is 1.29 and the pressure gradient is 4 into 1.29, 1.29, 5.8. So if systolic pressure is 40, then the pulmonary pressure would be 40 minus the gradient, that is 34.2. Am I clear in this? So if you know the systolic pressure and the systemic pressure is 40, then the pulmonary pressure is 40 minus the gradient, that is 34.2. Confused on your? I'll go little slow. So what you are doing is you are measuring the ductal flow, and if the pressure is high, you minus the systemic pressure from the gradient, you get the pulmonary pressure. And first of all, you have to see the shunt is happening in which direction. If it is bidirectional or right to left, you are dealing with the PPHN through the ASD or through the ductal flow. For this, the duct has to be patent. That's the second part. So you know the tricuspid regurgitation jet. Now you know the ductal shunting also. Now you're coming to the third point, which is slightly difficult to understand, but it is easy to do, but reliability is poor. Difficult to understand, easy to do, but not very reliable. Okay, this thing is known as time to peak velocity divided by a ratio of right ventricular ejection time. So a ratio of time to peak velocity and the RVET ratio. So what these two terms mean? In the next slide, we'll see what these two terms mean. This is, we are measuring the acceleration in the main pulmonary artery. So what we want to teach you is that if the अगर कोई चीज आपने उसको खोलना है, so the valve has to open up and there is lot of pressure behind. So what will you do? You will open with a thud. Initially it will open like tha, around ऐसे खुल जाएगा. But if the pressure is low, it will open very slowly. So if the pressure is high, the valve will open like thud. So what will happen is the time to peak velocity will be less, because you are giving a lot of pressure from the back. So time to peak velocity to reach at the peak would be less. So the time to peak velocity decreases as the PPHN increases. So time to peak velocity decreases, jaldi khul jayega, if the pressure is too high, if the PPHN is too bad. Fine. So this is measured in the short axis parasternal view. We position the range gate just beyond the tip of the pulmonary valve in the center of the MPA. Just beyond the tip of the pulmonary valve in the center of the MPA. This is based on the fact that pulmonary pressure rises. As the pulmonary pressure rises, the time to peak velocity, or the acceleration time, what we call as time to peak velocity, decreases or gets shorter. That's what I want to explain. It opens fast. And since it will be affected by heart rate, so what we do is we take the ratio. So right ventricular injection time, total time में से peak पहुंचने में कितना time लगा उसको. Okay. Now see this diagram actually. I don't have the actual. Yeah, you can see here. So what is happening here is there is a downward tracing. You can see the downward tracing. It goes down and then it comes. It comes back. Slowly it comes back. So if it goes down and reaches back, so this is normal tracing. But if it goes fast down, which means the time to peak velocity, peak is down, the time to peak velocity is very less, it means the pressure gradient is very high. I'm telling you, it is slightly difficult to understand, but once you start doing it, it's very easy to do. So coming back to a slide. So this diagram, see the second slide. This total is a RVET, right ventricular ejection time, and the time to peak velocity is the peaks. You can see there are arrows made. So this is in the second diagram I am saying. So time to peak velocity is almost half of the RVET. But as it moves down, as you can see the second, as it moves towards the left, the time to peak velocity decreases, RVET is almost the same. So the RVET to total proportion of the time to peak velocity is decreasing. So as it keeps decreasing, the PPHN becomes severe. So the ratios calculated are, if it is more than 0.3, so time to peak velocity is more, then it means it's normal. If it is between 0.2 to 0.3, it is moderate pH. But if it is less than 0.2, the ratio is less than 0.2, it is severe pH. So it is taking less than 20% of the time it reaches the peak. जितनी जल्दी peak पहुंचेगी उतनी जल्दी उतना ज़्यादा severe pH होगा. Okay, the last point is just this is a you can see this is a normal thing. This is a two-chamber view. Right ventricle, if the right ventricular pressure is too high, the septum will be deviated towards the left side. So you can see this diagram has been drawn. So this is the papillary muscle view. The papillary muscles in the left ventricle we can see. Papillary muscles in the left ventricle we can see. It is like a D-shaped. But once it presses, it keeps on becoming straight, and then the septum becomes straight, and then it is deviated towards the left ventricle. So IVS with convexity towards the left ventricle denotes that it is a PPHN case. So it is just to see as a view. There is no calculation in this. So if we summarize, to measure the pulmonary artery pressures, the first is the tricuspid regurgitation jet. It is repeatable, accurate, and there is a direct relation to it. The strong points are, it is again the accurate and the repeatable. Weak points is technically demanding. You have to have an exact velocity, you have to have the exact full jet, you have to keep the pulse wave, the continuous wave Doppler at a particular point. You can't change here and there at the valve point. So you should know the basic views so that you can come to this tricuspid jet velocity. Second is the ductal velocity. It is reasonable. There's an inverse relation, easy to measure, needs patent duct. If the duct is not patent, then you can't measure it. Then is the last, which we were discussing a lot actually, time to peak velocity ratio with the RVET, right ventricular ejection time. Repeatability is poor. You get some different value after this. Unpredictable, but easy to measure. So again, that line. Poor repeatability, many complicating factors. So the tricuspid jet velocity is the most important thing which you should actually know in this whole scenario. Thank you.
Thank you, Dr. Kamal. So you can please stop sharing your slides.
Yes, sir.
Yeah, thank you very much. So like, I know to start, if you are a starter, you haven't done it. Sometimes it's become very difficult to understand all these things, but you keep on getting it. But he has summarized it very nicely. But still, some people may, because you need repeated practice and repeated things to understand this. So what I will do, I will just show you on live baby 3 or 4 things, like basic 3 or 4 things where you diagnose and categorize PPHN. Views I have already told, and this will be just related to the PPHN. So again, I would say you, Dr. Kamal, if you can
Yes.
mute yourself.
Yes, sir.
Okay, and then people can select the speaker's view. Okay, and then you will be able to see what I'm trying to show in next 1 or 2 minutes, and then we will start with Dr. Tushar Parikh's shock lecture.
So, in my friends, this is the baby, and in this, we will just see a apical 4-chamber. In the apical 4-chamber view, we have to see whether the RARV is dilated, what is the position of interventricular septum, and we have to measure the TRJ. Okay, so that Dr. Kamal has already told you, this is with the continuous wave Dopplers, and this will give you the gradient of RV to RA, and we have to add 6 to 10 to that. So that will be our TRZ right-sided pressures, and indirectly to a pulmonary artery. And then other thing we have to see is pulmonary artery Dopplers. Instead of just doing the ratio, if you just see the shape, if it is isosceles triangle, it is normal. Right angle triangle is moderate pulmonary hypertension, and if you see a notching in the pulmonary artery Doppler, it is severe pulmonary. And then in short axis, I will show you where to look for the interventricular septum position, what he showed in the last. So again, we will start with upright apical 4-chamber view. So again, this is the probe. My pointer is pointing towards 2 to 3 o'clock position. I am keeping it at the apex. Okay, and this is my apical 4-chamber view. And as you can see in this, your dominant chamber is basically LALV. LALV is bigger. Now, and you can see this. This is I flat or more on the right side. So if it is pulmonary pressures are high, then what would have happened? Your RARV will be dilated, bigger, and this interventricular septum will be bulged like here. So that's how you can judge whether it is RARV which is dilated or LALV. So this is just by seeing in a apical 4-chamber 5-chamber. So when you put on the color, see, I have to go up on the scale because scale is not appropriate. As you can see, if I put the scale, the color is not. Okay. So now you see, this is red color is from RA to RV towards the probe. That's why it is red. So TR is flow of the blood from RV to RA. So it is away from the probe. So it will be blue. So anything blue in this atria up the tricuspid valve, it is tricuspid C. This is tricuspid leaders. Okay. So if I have to calculate my tricuspid leaders, I have to put a color. Okay. Take the cursor in this blue jet and hit my continuous wave Doppler. and you see this is my jet, because it is not very significant. This is the jet. Blue is always below the line. If I have to calculate, I will hit my caliper button, okay, and automatically the machine will, we have to go for the maximum this thing, and machine takes this. And as you can see, the machine has calculated the gradient as 3.4. We had 6 to 8, so the right-sided pressures are around 9. Okay, so they are less than 25, so there is no pulmonary hypertension. This is how we measure the TRJ. Okay, so we have seen apical 4-chamber view, RARV, interventricular septum, and we have measured the TRJ. And then now we will see how to do the pulmonary artery. As you can see, this pointer again has gone up. We will do plaques, standard plaques view. So again, pointer at 11 o'clock position, you will get the plaques view. Then you sweep up and you start seeing the pulmonary artery. You can put on the color for pulmonary artery. This transfer upright flow is pulmonary artery. Okay, you hit the cursor, take the cursor there in the MPA, main pulmonary artery, and hit pulse rate. So these are the Dopplers of the pulmonary artery, and as you can see, it is an isosceles triangle. So it is normal. If it is right angle triangle, it is sphere, and then if there is a notching pattern, you see notching pattern, then it is sphere pulmonary artery. And then at same place, if we do parasternal short axis, and this is what you will see. So you see this, the parasternal short axis at papillary muscle level. So what you see, interventricular septum, this is interventricular septum. If you see LV is circular like this, then it is not pulmonary hypertension. If it is flat, so it will be D-shaped, it is moderate. And if it is convex, like it invaginates into this, this interventricular ventricular septum, invaginates into your LV, then it is severe pulmonary hypertension. So these are the 3 things we mostly see for pulmonary hypertension.
So now I would request Dr. Tushar Parekh to start with the views for the shock. Dr. Tushar Parekh, please. Dr. Tushar. Dr. Tushar, are you able to listen to me? सर, आपका प्रेजेंटेशन है सर. Okay, Dr. Tushar Parekh is being coming within 2 minutes. So I don't know if there are being questions till now. Any of the moderators, they can ask us. So we will discuss till now whatever the presentations we have done. So we will try to answer those. Anybody? Because I know there are 2 platforms different, so we won't be able to see the questions by the participant.
Till now, there are no questions, sir.
So till now, there are no questions. Okay, fine.
Okay.
So no questions means very well understood or not understood?
Yeah, I think so. Okay. So till Dr. Tushar Parekh comes, I will just show you that what are the main views for shock and what we do. Then he can do the this thing. Theoretical part of it. I will finish up the practical part of it. So again, you can click on your speaker's view and we will start that.
I think Dr. Pradeep has come.
Hello, Dr. Suryavanshi sir.
Sir, you unmute yourself. Yeah.
Good afternoon. Good afternoon. Hi.
Good afternoon, sir. So Dr. Pradeep Suryavanshi, everybody, I introduced you before when we started. So, sir, Tushar is busy somewhere.
Yeah.
Wait. So, agar you can start with you can start with your PDA this thing. So, is
Yes.
it possible? Na?
Yeah. Give
So
me
please.
1 minute. I will
Yes,
start.
sir. Yes, sir.
Can you able to see my screen now?
नहीं सर.
No, no, no.
आप शेयर स्क्रीन कर रहे हैं सर? शेयर स्क्रीन पे जाएं.
1 मिनट. नाही दिसत मला. तू या इकडे. जाऊ दे, तू पहिले कर.
Exit minimize view and share screen and
सर आपको अपना पीपीटी पहले मिनिमाइज करके रखना पड़ेगा सर.
Yes. अभी आया क्या?
हाँ सर. आया सर.
There now. Yes.
And voice and video both are on और कुछ है?
Both audible, well audible.
सर वीडियो आपका बंद है. वीडियो बंद हो गया आपका. अनम्यूट कर लीजिए सर. अपने आप को अनम्यूट करिए.
अनीश.
हाँ हो गया सर.
Okay, fine. All right. All right. So I think we have covered the basic aspect about the views. We have covered the lecture on the PPHN and shock. Now we will be covering the lecture on hemodynamic assessment of the ductal shunting. So in next 30 minutes, we will try to cover how we are going to diagnose the ductal shunting. So most important thing, we will have to imagine basically the three component: actual visualization of duct and complications of the duct in the form of pulmonary overcirculation and systemic hypoperfusion. And then we will grade these duct. So these are the three angles we are going to sort out in this lecture. We all know the most important effects of the duct as the left to right shunt, which is a high volume left to right shunt, leads to the pulmonary overcirculation and pulmonary edema, hemorrhage, BPD as a long-term effect. While there is issue associated with the systemic hypoperfusion, this systemic hypoperfusion actually reduces the blood flow to the major organs. That means there is a risk of NEC, renal failure, IVH, and LV dysfunction. So when we are thinking about the duct, we have to categorize this duct in the form of visualization and complications of this duct on the lung, that is a pulmonary overcirculation, and complications in the form of systemic hypoperfusion. So these are the two things we are going to observe in this lecture. So I just mentioned you that the duct characteristics, we will see the size of the duct, we will see the duct flow pattern, we will also evaluate the duct in the form of pulmonary hypoperfusion as a left heart size and left side functions. We will see the hypoperfusion as the descending aorta Doppler, SMA Doppler, or we will also see the anterior cerebral artery, renal artery Doppler. So these are the major things we need to categorize the duct on the basis of echocardiography. So it is not only you have seen the duct and you have measured the duct 2 millimeters and then you started treatment to the duct. No, you need to categorize that duct. You need to monitor hemodynamic effects of the duct and then go ahead from that angle. So the first important thing what we are going to see is the crude marker, what we usually do. That is called as diastolic turbulence in main pulmonary artery. So in the first lecture, you saw that the short axis view. You saw the short axis view. In the short axis view, you visualize the main pulmonary artery. And in that main pulmonary artery, if you put a Doppler, so put a pulse wave Doppler. If you put a pulse wave Doppler, then what you will observe in this pulse wave Doppler is just 1 minute. The videos are just trying to sort out. So I will go back to the videos. So this is the normal Doppler of the pulmonary. That is the what we saw, the negative deflection, because the blood flow is away. In that, there is a minimal this turbulence is available. So this is the laminar flow into the pulmonary artery. But if this laminar flow turns out with a maximum turbulence, so there is a laminar flow of pulmonary with the turbulence, then you consider that there is a blood flow which is coming from aorta to the main pulmonary trunk, and that blood flow has having more turbulence. So this is called as diastolic turbulence in main pulmonary artery. So that's the first marker that there could be increased circulation, and that increased circulation could be because of PDA. Okay, so this is the most important marker. So you can see this is the classic thing. This is the normal pulmonary. Can you see this is the normal pulmonary Doppler? This is MPA, and you have put the Doppler. This is the normal. While there is a minimal disturbance here there is a marked disturbance in this picture. So when you put a pulmonary, this is the laminar flow and there is a marked disturbance. So there is a chance that this baby could have PDA. That is the first thing, because the blood flow is increased to the main pulmonary artery. What is the next thing? The next thing, that means if the blood flow is more in the main pulmonary artery, ultimately the blood flow will be more into the right or left pulmonary artery. So we need to see that Doppler into the left pulmonary artery. When you put a Doppler in the left pulmonary artery, which is good for angle of insonation, when you put a Doppler in left pulmonary artery, good thing is that you will see the systolic and diastolic, but the diastolic velocity is less than 0.2 meters per second. When you see that this diastolic velocity is increased, that means there is an increased blood flow into the left pulmonary artery. That means there is a shunting happening from aorta to the main pulmonary artery, from main pulmonary artery to the right and to the left. So what we saw, two things. We saw marked turbulence into the main pulmonary artery. We also saw increased diastolic flow into the left pulmonary artery. That is the more important marker. That indicates there is a pulmonary overcirculation. So this is the first marker I would like you to remember. When your diastolic velocity is more than 0.3, you can consider the moderate PDA. If the velocity is more than 0.5, you can consider this could be the large PDA. This is the marker, crude markers. So this is the classic. So this is, you can see this video. This video shows there is the velocity which is less than point. This is the diastolic velocity. This velocity is less than 0.2, so there is no duct in this baby. While here you can see the velocity is 0.3. This could be moderate PDA. This velocity is 0.4. This could be large PDA. So these are the examples of normal, no PDA, mild to moderate PDA, while this is a large PDA into the LPA. Once you see that onto the short axis view, now it is time to visualize the duct. How to visualize the duct? We saw in the first lecture as the ductal view. So you need to see that the baby who is the short axis view, rotate that short axis view in an anti-clockwise. So once you have a short axis view, rotate anti-clockwise and go a little bit right, or basically the right side suprasternal, that is your ductal view. And in that ductal view, you actually visualize. So this is the visualization of the duct. In that visualization, the gray scale, you will see 3 legs, 1, 2, and 3. So this is the RPA, LPA, and the duct. So these 3 views, that is called as the ductal view, where you cannot see the aorta clearly, but some part of the aorta can be seen. This is called as a 3-legged stool appearance. You need to identify duct in the gray scale. Once you identify in the grayscale, put a color. So you can see the color now here, RPA, LPA, and the duct. The duct, this is the blue color because it is going away from the probe, while this is the red color because aorta to the pulmonary, that's the red color. So can you see this baby, which are 3, 1, 2, and 3, while this is the aorta. So bright flare on color is the confirmation that this baby has the duct. So grayscale will see that there is a duct, while color Doppler will confirm that this baby has the duct. Now once you confirm that duct, we need to measure that duct. So this is the first thing as grayscale and color. While you can easily say that this duct, which is a small duct, or this duct is a constricting duct. This is the pulmonary trunk and this is the aorta. While here, very small, which is a constricting duct available in this baby. At the same time, if you see here, there is a no duct. That means this baby's duct got closed. This is the pulmonary trunk and aorta, while the duct got closed. So you can confirm by the gray and color that duct has been closed. If you measure the duct, which is the most important thing, you can say here this is a small duct on the visualization. But once you zoom also, that duct can look large. So this is a big duct on visualization. This is a small duct. So now when we see this is a small duct and this is a big duct, on that one, you need to measure by color Doppler. So most important thing is that once you have done the grayscale, put a color. Once you put a color, freeze that frame. And once you freeze, measure towards the pulmonary end of a narrow part of the duct from end to end. Can you see here? This is the duct towards the pulmonary end. This is the pulmonary. This is the main pulmonary artery, RPA, LPA. And this towards the pulmonary end, you measure the duct from end to end. If the duct is more than 1.5 to 2, you can consider moderate duct. When it is more than 2, it is usually significant, hemodynamic significant duct with other markers. So what we learned so far? We learned the duct visualization. We learned duct measurements. Once we have measured the size of the duct, we need to put a Doppler in the duct. So direction and the pattern of the duct can be measured by putting the Doppler actual into the duct. So this is the again same view, RPA, LPA, aorta, and this is your duct which you have put a pulse wave Doppler towards the pulmonary end. So you need to put a pulse wave Doppler towards the pulmonary end to find out direction and pattern of the duct. That means you want to categorize whether this duct is left to right, this duct is bidirectional, or this duct is right to left. What today we are dealing? Hemodynamic preterm left to right duct. That means we are dealing with a preterm PDA which is left to right. We are not dealing here bidirectional, or we are not dealing here right to left duct, because bidirectional PDA or right to left goes in the previous lecture of PPHN, what already the team has covered. So this is the classic. You can see this one. This is the classic picture of the color Doppler, and you can see if I put a Doppler, once I put a Doppler towards the pulmonary end, you can see the positive deflection of a pulsatile left to right duct. So this is called as pulsatile left to right duct, and with the size more than 2 mm with left to right with associated pulmonary overcirculation or systemic hypoperfusion, these are the ducts which you require help. That is the first thing. This is a classic pure left to right duct. While this is the bidirectional duct, when you put this duct, you could see the red color. But once I put a Doppler, there is a component of left to right. This is the left to right component, while this is a right to right, right to left component also. If your right to left component is more than 30%, then that is a classic bidirectional duct. Here, the component of the cardiac cycle is less than 30%, hence it is still left to right duct. If this duct increases, can you see? This is the red color, but there is a blue color also inside. When this duct has a left to right component, plus right to left component. There are two components here, left to right plus right to left component. So this is the bidirectional duct. You don't treat this duct with the whatever we are dealing with, whether ibuprofen, paracetamol, or old days indomethacin. These ducts are not the one which to be treated. These are the PPHN ducts. While this is the classic right to left duct, that means the baby is in severe form of pulmonary hypertension. This is the classic right to left duct. You are in big trouble. What today we are discussing? We are discussing pure left to right duct. So this is the baby who is before probably the death. This is the classic right to left duct, and you can see the right to left pattern. So what we saw? We saw the grayscale, we saw the color, we have visualized the duct, and we put a Doppler towards the pulmonary end of the duct. While putting that Doppler towards the pulmonary end, we realized that the duct is positive deflection, that is a right to left duct. Okay, so far so? Let's go ahead. So these are the classic patterns you will see. These are the classic patterns what you will see. This is a right to left duct, not to be treated by brufen paracetamol. Bidirectional duct, again not to be treated by brufen paracetamol duct. C and D, this is the growing and pulsatile duct. C and D, these are the growing and pulsatile duct. These are the hemodynamic significant left to right duct. While the E is a closing duct or construction happening, constructive duct. These are non-constructive. These are the hemodynamic significant duct which you requires a treatment. So this slide is a very important slide to categorize the duct which you have to know. So just now we saw the parameters of the ductal shunting. You visualize the ducts by grayscale. You put a color, measure the duct, and you put a Doppler and categorize that duct as basically pulsatile or non-pulsatile. That's the three parameters when you visualize the duct. Very, very important aspect. So first thing we have covered, duct characteristics, size of the duct and pattern of the duct and direction of the duct. Now consider this second pattern, the markers of pulmonary hyperperfusion on echocardiography. So what has happened? Because of the duct, the blood which was supposed to go to systemic circulation, because of the left to right, from aorta, it is coming towards the pulmonary trunk. That's why there is more blood to the pulmonary trunk. From pulmonary trunk to the lungs. So the lungs are overflooded. Lungs are with pulmonary edema. So once the lungs are edematous, that same blood comes to the bipulmonary veins to LA, and hence left side of heart looks dilated. So in a 4-chamber view, you will see LA and LV dilated. That is a first marker that there could be pulmonary hypoperfusion. While in cases of pulmonary hypertension, you will see RA and RV dilatation. While in case of PDA, you will see LA and LV dilated. That is the simple first thing, differentiation between PD and PPHN, what you will see. What are the other markers? Other markers is that when you want to measure the LA, the classic marker of measurement is LA-AO ratio. So when you say that we want to measure the LA-AO ratio, measurement is to be done by M mode. The first class was the views and modes. That time we have mentioned you that M mode. So the M mode measurements, you need to do the parasternal long axis view. So you already know the parasternal long axis view as the probe markers towards the right shoulder. That is what parasternal long axis view. Where in the parasternal long axis view, you will see LA, you will see LV, you will see the right ventricle and aorta. What we want to measure? We want to measure this LA-AO. So if I put a M mode here, so this is a picture of M mode. If I put a M mode to this LA-AO, this is the picture what I got. So this is the aorta and this is the LA on grayscale. If I put a M mode here, this is the M mode, I get aorta as the box and then LA. I need to measure LA in the diastole. Very, very important here. Measure the LA in diastole. While measurement, you have to measure from end to end. So this is very important again. This is the end of the aorta, while another end of the aorta. Diastole, one end of the LA, another end of the LA. This is the where you measure the LA-O ratio. Normal LA-O ratio is less than 1.4. When the left atrium is dilated, LA-O ratio becomes more than 1.5. So when you have LA-AO ratio more than 1.5, that is the marker of pulmonary hyperperfusion. marker of lung overload, marker of LA dilatation. So second marker of dilatation, 4-chamber view we saw LA-LV dilatation, parasternal long axis view, M mode we have measured LAO, that is LAO ratio. Second thing, you can also measure the left ventricle. So same view, parasternal long axis view. If you measure the left ventricle, which is called as left ventricle end diastolic volume along with aorta, if it is more than 2, then that is also LV dilated. So LA more than 1.5, LV more than 2. These are the two simple markers you can measure on LA, LV. LAO ratio, these are the normal ranges, but I told you more than 1.5 LAO ratio, more than LVDD more than 2, that is what LA dilatation and LV dilatation, which is called as volume loading of left side of heart. That is because of pulmonary hyperperfusion. You might also measure, these are the advanced things, you might also measure the left ventricular output by the techniques, and you can document that your left ventricular is more than 250 ml per kg per minute, and that is also marker of left sided heart dilatation, but I will not include in the discussion here today. So measurement of LAO ratio, measurement of LVDD-AO ratio and LVO, these indicates pulmonary hyperperfusion. Another marker is EO ratio, but again, I will not go here. So the important markers, what I will go here, the first marker I will go here is LAO ratio. Second marker I will go is LV-EDD-AO ratio. And third marker I will be going is left ventricular output. But these are the additional markers. There are additional markers in the form of pulmonary vein Doppler. There are additional markers in the form of, I already told you one marker, which is LPA diastolic. This is the LPA diastolic. So LPA diastolic more than 0.3 is also a marker of left ventricular volume or LA-LV volume overloading, left-sided volume overloading, marker of pulmonary hyperperfusion. Okay, I will repeat again. That first thing we have saw the duct. Second thing, markers of pulmonary hyperperfusion. Markers of pulmonary hyperperfusion, apical 4-chamber view, LA-LV dilated, that is the crude marker. Second, you measure LAO ratio, parasternal long axis view, M mode, LAO ratio more than 1.5, that's marker of pulmonary hyperperfusion. Parasternal view, M mode, LVDD-AO ratio more than 2, marker of pulmonary hyperperfusion. Next, left ventricular output more than 250 to 300 ml per kg per minute. That means there is more volume load on the left side. Additional two markers, one marker we already saw is LPA diastolic. LPA diastolic more than 0.3 meters per second. That is what we can consider these babies have left-sided volume overload. Additionally, we can do the pulmonary vein Doppler. So this is the pulmonary hyperperfusion. Next thing is systemic hypoperfusion. So when we consider systemic hyperperfusion, what happens? The blood which was supposed to go to the aorta, which is not going in aorta, which is going backward, and hence there is a ductal steal. That means blood is not going to anterocerebral artery, blood is not going to mesenteric arteries, blood is not going to the renal artery, and blood is stealing. The aorta is stealing, duct is stealing. So from aorta, the blood is in the duct. That is what we measure the ductal steal, and we see the Doppler into the major arteries. So what is the major artery Doppler? This is the ascending aorta before the duct. Ascending aorta, systolic diastolic. This is the ascending aorta, systolic diastolic. That is normal Doppler. But if I put a Doppler in descending aorta, this is the descending aorta Doppler. If I put a Doppler in descending aorta, normally you see systemic and diastolic. But in cases of the duct, there is no flow into the descending aorta in the diastole, or there is a reverse. That is the marker of hypoperfusion. So in this baby, can you see here? In this baby, there is no flow, absent end diastolic flow in the descending aorta, marker of hypoperfusion. Similarly, in this baby, there is a reversal of flow. Can you see here reversal of flow? Left to right shunt and here right to left. So this is a reversal of flow into the descending aorta. So this baby has definitely hemodynamic significant duct. Similarly, if I put a Doppler into the anterocerebral artery, you can see the normal. This is the normal systolic diastolic. But if it is absent here, can you see here absent? So these are the one absent flow. These absent flows is indicative of hemodynamic significant duct. While here we put a Doppler in SMA, that is a superior mesenteric artery, or you can put in a celiac, but SMA is a good one, systolic and diastolic, but here there is a reversal of flow into the SMA. So these are the markers of systemic hypoperfusion. Renal artery, similarly, you put a Doppler in renal artery, normal flow, while reversal of flow in the renal artery. So what we saw that the markers of systemic hypoperfusion are Doppler in descending aorta could be absent reverse, Doppler in ascending aorta, anterior cerebral artery or middle cerebral artery, absent or reverse, Doppler in SMA, absent or reverse, Doppler in renal artery, absent or reverse. These are the markers of systemic hyperperfusion. What this is the normal, this is the absent, and this is the reverse. Normal, absent, and reverse. So these are the classic example of these two are hemodynamic significant PDA. These two are hemodynamic significant PDA. So at the end, we need to grade this duct. What to grade? Duct diameter, LAO ratio, and descending aorta flow. So one marker from each category: marker of the duct, marker of pulmonary hyperperfusion, marker of systemic hyperperfusion. If it is less than 1.5, LAO ratio less than 1.4, and antigrade flow, this is not hemodynamic significant duct. Duct size more than 1.5, LAO ratio more than 1.5, absent flow, hemodynamic significant duct. The size more than 2, LAO ratio more than 1.5, reverse flow, hemodynamic significant duct. So these are the criteria what we consider as the markers of hemodynamic significant duct. What is important to remember here is that the duct and duct characters will be always there. They will be always there. But to come this pulmonary hyperperfusion and systemic hyperperfusion, you will have to wait some time, basically mostly 24 to 48 hours. Then this complication comes, and then you need to analyze these markers, because these will not be there immediately in the first 24 hours. So that's what this is overall all three characteristics what we just discussed. Basically the duct characterization, pulmonary overcirculation, systemic hypoperfusion, all those things we need to monitor when we are dealing with this one. And this is what my take home message here, that one marker of the ductus, one marker of the pulmonary overcirculation, and one marker of systemic hyperperfusion. If you practice in day to day, you will be quickly learned. There are other markers also, there are additional markers also, but I would say that concentrate on these ones and go ahead with this one. With this, I think I will stop here. Thank you.
Thank you, sir. Thank you very much. As usual, it was very crisp, very informative, and direct to the point. Thank you very much for this. And I don't think I should be showing any views, because multiple views are there, and we have already discussed the views on the baby. So again, it will be a advanced things, but it is very nicely been explained. And now we have another our top batsman, Dr. Tushar Parekh. He will be discussing the shock. Sir, Dr. Tushar Parekh, please. Sir, Pradeep sir, आप अपना screen sharing stop कर दीजिए, sir.
Thank you, Dr. Mohit. I'm getting a feeling that I'm coming to bat after Sachin Tendulkar and Virat Kohli. First of all, I thank the organizers of Raj NeoCon, Dr. Anurang Singh, Dr. Pradeep Jain, Dr. Neeraj, and Mohit for inviting me for this workshop. In the next 25 to 30 minutes, I will talk about neonatal shock and how functional echocardiography in a situation of shock will help you in understanding the situation and help in management of the patient. My screen is visible? Is my screen visible?
Yes, you are visible.
Screen is visible, huh?
No, screen
Yes. Screen is not visible.
Okay, sorry. Let me first share it. First, 1 second, please.
सर अपना पीपीटी मिनिमाइज करके पहले रखिएगा।
एक सेकंड ना, मैं ये मिल नहीं रहा। हाँ, यहाँ पे है।
आपने पीपीटी मिनिमाइज कर दिया ना, तो शेयर स्क्रीन ग्रीन वाला एरो उस पर दबाएंगे तो वो सारा शेयरिंग वाला खुल जाएगा सर।
वो दिखने, एक सेकंड।
नहीं, आपने अपना पीपीटी मिनिमाइज किया है पहले, खोल के मिनिमाइज करके रखा हुआ है?
हाँ हाँ, मिनिमाइज करके रखा हुआ है।
तो आप नीचे एरो लेके जाइए ना, अपने स्क्रीन के
हाँ
एरो में नीचे लेके जाएंगे
या मिल
तो
गया।
शेयर
यस
स्क्रीन आएगा।
यस यस यस। Yeah, I think it's visible now.
दिख रहा है सर अभी?
Yeah. So let's begin. So first couple of slides regarding the basic aspects of shock, which we all need to remember when we are dealing with shock. Basically, shock, we know, is a situation of circulatory insufficiency where there is supply and demand situation where the demands of the body are not met for the delivery of oxygen and nutrients. And generally, hypoxia and acidosis are the ones which cause tissue damage. In the situation of shock, we know that shock is not equal to hypotension, and hypotension is a late sign of shock. So when hemodynamically we look at shock, there are three situations. Basically, it may be related to decrease in volume of the blood, which is hypovolemic shock, as we all know. It may be related to decreased ability of the heart to receive or pump the blood, that is known as cardiogenic shock. And third one is related to poor vascular tone, and that is, we know that may be redistributive shock. So basically, when we look at shock situation hemodynamically, these are generally three important situations that we try and understand and diagnose underlying hemodynamics in order to provide correct therapy. We know the causes of hypovolemia, cardiogenic shock, and abnormal vasoregulation. In a clinical situation, if you see, as a neonatologist, these are the common situations where you would face situation of shock. A very low birth weight baby during transition in the first 1 or 2 days, a baby with large PDA, term baby with persistent pulmonary hypertension can have shock sometimes. Hypoxic ischemic encephalopathy, the heart myocardium is injured and that can have shock. Sepsis situation, very important in sepsis, with or without PDA, again complicating the matters with PDA. Congenital heart disease, volume depleted states, and sometimes post-surgical situation where there may be cardiac surgery or non-cardiac situation where there may be shock. So the point here I want to make is that same therapy will not suit all because the underlying pathophysiology in each one of them is different. And unless we address the underlying pathology, we will not be able to get over this shock. Up until recently, there was over-reliance on blood pressure as a marker of shock. And in one of the Canadian surveys and one of the surveys which involved more than 200 neonatologists across the globe, almost 75 to 87% of neonatologists said that they will treat hypertension, they will treat shock if the blood pressure is less than mean post-menstrual age. So BAPM criteria, what they've said is blood pressure less than baby's post-menstrual age. So if the baby's blood pressure is less than post-menstrual age of the child, so if the baby is 30 weaker, then the general rule would be to keep the mean blood pressure above 30, and that is what everybody has been following for so many umpteen number of years. So now that has been challenged, and the people who do point of care echocardiography, they would not treat babies just based on the blood pressure. There are a series of studies which have come from Martin Clockpoint group from Sydney, and this particular study was done by David Osborne. What they've shown is that the mean blood pressure had they monitored mean blood pressure and superior vena cava flow, and SVC flow is a marker of systemic blood flow or marker of a cardiac output in a baby who has PDA. And in that situation, what they showed is that there were a lot of babies in which the blood pressure was less than 30 mean blood pressure, but their systemic blood flow or the cardiac output was good. And there are a good number of babies in which the systemic blood flow was less, but their mean blood pressure was kind of normal. So again, telling us that any one of the parameters is not good, and we have to look at both the parameters. So people have been looking at signs other than blood pressure, such as capillary fill time, urinary output, heart rate, color of peripheries, blood gases, and movement activity, so on and so forth. All these signs people have been watching at variable degree and relying on them to understand the presence of shock. But if you see ancillary investigations which are used nowadays to assess the shock, the most common is echo, and people are now also using NIRS for the measurement. So now coming to the assessment. So as a point of care echo person, when you are facing a baby with shock, what we assess for these 4 or 5 parameters. We assess for the preload, we assess for the cardiac contractility, we assess for the cardiac output, we look at the hemodynamically significant duct. That part Dr. Pradeep has already covered, so I will not touch upon that part. And we overall screen the heart for the structure of the heart, and that is also Dr. Mohit has covered. So basically what I'm going to speak now is on these 3 important aspects. One is preload, assessment of the preload, assessment of the cardiac contractility, and cardiac output. Now, how do we assess the preload? Now, assessment of the preload in the newborn, there is a facility of CVP is not there. So generally what we have to rely upon is the look at the IVC. And to look at the IVC, we put the probe at the junction of upper 1/3 and lower 2/3 of a line joining xiphoid and umbilicus. That is basically the subcostal long axis view, where the pointer is pointing towards 12 o'clock. And we put this probe in the subcostal area and try and get the place where the IVC is joining the right atrium. Now this is the point. From there about 1 to 2 centimeters down that point, you assess the IVC. So you measure the IVC diameter there. So this is again an image where you can see the IVC is running. This is the subcostal long axis view. The IVC is running into the right atrium, and about 1 to 2 centimeters from the RA IVC junction, you measure the diameter. As seen here, it is 0.44 centimeters, and you put the M mode there. And once you put the M mode, you get the respiratory fluctuations or variations which happen in the size of the IVC. And as you can see, the diameter is varying between 0.46 to 0.37 during inspiration. So again, here we have to remember there is something called a cylinder effect. When we are measuring the diameter of the IVC, we have to ensure that we cut the IVC through the center and not from the side. Because if you are cutting it from the side, you are going to get a falsely low measurement. And therefore, when you're doing this IVC size measurement, you have to kind of put the probe and you have to tilt it in a way that where you get the maximum diameter of the IVC. Now, again, the assessment of the preload based on the size of the IVC or IVC variation again has not been categorically well studied in preterm neonates. Now, there are studies about in full-term babies where they've shown if the size is more than 8 and if it is less than 50% collapsible with respiration, then it is normal. However, if the size of the IVC is less than 8 millimeter and if it is more than 50% collapsible, is definitely fluid deficit. And if it is size is less than 8 and less than 50% collapsible, maybe fluid may help in this situation because the fluid status is borderline low. And in a situation where the diameter is more than 8 millimeters and there is no inspiratory collapse, or the collapse is less than 50%, when there is no inspiratory collapse at all, then it is definitely RV failure and high pulmonary pressures, and therefore this baby one should not give fluids. You should in fact diuretics. There are studies in newborn. Now this particular study again from Japan, what they've done is that they've studied the diameter of the IVC and they've compared it with CVP, and what they've shown is that the diameter of the IVC, the smallest diameter of the IVC correlates well with the gestation age. And what they've shown is that the ratio of smallest diameter versus the largest diameter has got good correlation with CVP. As you can see, there is a linear correlation. And if you draw the ratio, if the ratio, as you can see, if it is less than 0.6 as per this chart, most of the times your CVP is going to be less than 5. And if it is the ratio is more than say 0.9, the most of the times the CVP is going to be high. Now there are situations where the ratio is normal, like 0.6 or 0.7 or 0.8, still the CVP is low. So again, this will not be able to kind of 100% be sure and accurate. But of course, if the ratio is less than 0.6, you are fairly certain that the CVP is going to be less. Again, there are other pointers. Unfortunately, there are not clear-cut numbers or numeric values as the one which I said to you. Besides that, you have to just, there's a lot of emphasis on the visual impression of the LV and RV size, the dimensions. And if they are hypovolumic, they will appear more hyperkinetic. the small LV end systolic and end diastolic areas, ejection fraction if you are calculating, and that will come most of the times more than 70%, which is very high, and that would indicate presence of hypovolemia. Also, small IVC diameter with wide respiratory variation, if you're seeing, again, that would indicate that there is a low preload. So these are the situations where you would think about giving a volume, and that you know that the cause is low preload. I have certain cases I will show at the end if the time permits. Then second important aspect which I'm going to discuss is about cardiac output. Now, there is a lot of controversy whether you should measure left ventricular output, whether you should measure right ventricular output, or whether you should take SVC flow as your marker of cardiac output. I will go through all pros and cons of them. But important underlying mechanism, how do you measure the cardiac output, is same for all. Basically, cardiac output is a volume of blood which is pumped by the heart, and it is expressed as mLs per minute per meter square of the body surface area. In the neonate, it is expressed as per kg. So in fact, when in neonates, when you actually express as cardiac index as per the adult, but we call it as cardiac output only. So cardiac output is equal to stroke volume multiplied by heart rate. And how to calculate stroke volume? Stroke volume, this is a formula that mean velocity of the blood which is going through the vessel in that particular vessel multiplied by the cross section area of the vessel. And what is the measure of mean velocity of the blood? VTI, that is velocity time integral, is the measure of mean velocity of the blood which is going from that vessel. And so that is how you calculate. So how do you calculate for the LV output? So let's first see left ventricular output. So what you do is that you take an apical 5-chamber view as per Dr. Mohit has shown in the morning some time back, and you measure the blood flow velocity just beyond the aortic wall in the plaques view, and in the plaque. So this is apical 5-chamber for measuring the velocity, and plaques view to measure the aortic diameter, and calculate the cross sectional area by pi r square. So you get the aortic root diameter area. So, and the normal values of LV output is 150 to 300 ml per kg per minute. So now this is the procedure. So you take the apical 5-chamber view, put the probe at the apex, first obtain a 4-chamber view, and then slight clockwise rotation, and then see the open of the aortic valve here. As you can see, this is the apical 5-chamber view. So here is the aortic valve. So what you're going to do is that you're going to put your Doppler gate somewhere here and measure that and put the pulse wave Doppler. So as you can see, this is the inverted image. The pulse wave Doppler is in the aortic root, and what image you get is like this. Now this is the left ventricular outflow tracked velocities, and if you track those velocities, most of the machines will give you what is called as VTI. As you can see, this is VTI. So you kind of track this, and once you track this and press the button, you will get VTI. So VTI basically indicates the average velocity of the blood which is going from that diameter area. And how to measure the crossing, how to measure the cardiac, the aortic root diameter? By parasternal long axis view. So place the probe. Dr. Mohit has explained how to take the plaques view, and in the plaques view, what you see is the aortic root. Try and obtain a good plaques view and find out the aortic leaflet. So if you see, this is the aortic leaflets. They are attached here at this hinge point. So this is the one hinge point, and this is second hinge point, and this is the wall. When they join together, they form shape like that. So this is the shape here. So at the aortic root hinge points, you measure the diameter, and that is the diameter which you put as pi into radius square, and you obtain the surface, the area of that aortic root, and you have the VTI value. So so that is how you calculate the cardiac output. Then coming to the right ventricular output, again in the right ventricle, again the same method. You try and obtain the VTI in the pulmonary artery and obtain the cross-sectional area of the pulmonary wall and put it in the equation, and you will get the this thing. You will get the cardiac output. Then coming next to, so this is how to get the pulmonary artery view. So you have to use the parasternal short axis view. And in the parasternal short axis view, you will see the pulmonary artery like this. Put a Doppler there and see the velocity. Now, studies have shown that instead of in detail calculating the surface area of the cross-sectional area of the pulmonary wall, just looking at VTI or peak velocity of the main pulmonary artery vessel, you can get an idea whether the baby has got any low output state. So in case, so if the normal so the normal peak velocity of blood flowing through the main pulmonary artery is generally above 0.45. So studies have shown that if the velocity, as you can see, if it is 0.35 to 0.45, it is cardiac output is borderline, and if the velocity is above 0.45, then generally the cardiac output is normal. So in case this is a borderline, and if the peak velocity, so which is the peak velocity? So this is the velocity of the blood which is going through the main pulmonary artery. This is showing 50. So if I'm getting a trace like this in the main pulmonary artery, velocity which is more than 45 centimeter per second or more than 0.45 meter per second, then I will say that this is a baby is having good cardiac output. As against this situation where the right ventricular outflow tract, main pulmonary artery is showing poor velocity, this is having a poor cardiac output. This is just eyeballing. This is just a simple method rather than going in detail of taking a diameter and calculating it. Then coming to the SVC flow. SVC flow, because this is a basic workshop, I will just skip how to measure it because it is too complicated for new people, and even the people who have invented this SVC flow, they are not using it today. They are using it for the research purpose because its validity is still not well established. But again, SVC flow, basic idea is that the blood which is coming back to the heart from the superior vena cava represents systemic blood flow from the upper half of the body and the brain. And we are more interested in circulation or blood flow to the brain, and this has got a good correlation with overall cardiac output. And this also kind of negates the effect of the PDA, because if you are just measuring the LV output, the blood which is going out from the left ventricle, part of it is going back into the pulmonary circulation through the PDA, and therefore that is of no use. And therefore this is a kind of a considered as a better marker. This is how you get the SVC diameter. You have to take 10 readings and take the average of SVC, because SVC is a collapsible structure and therefore the reading may be inaccurate. This is a subcostal long axis view, and from the subcostal axis long axis view you find out the SVC and try and get the pulse wave and try and get the VTI of the SVC from the subcostal view. Studies have shown that SVC flow is a better marker of systemic blood flow. Okay, so now coming to the third important aspect of assessment of the babies with shock is the assessment of the systolic function. Now again, the assessment of the cardiac function is an area of intense research. There are a lot of things which are there, right from left ventricular function, right ventricular function, systolic function versus diastolic function. There are tissue Doppler, there is a perfusion index. So there are many other things which are there in kind of assessment of systolic function of the heart. And diastolic function itself is a separate chapter. So basically what we restrict, so most of us, what we do is that first impression is very important. So when you look at the heart, if the heart is hypercontractile, normally contractile, mildly reduced contractility, or poorly contractile, so we try not to lose the classification. But when you look at a heart, you will get a kind of idea whether the heart is, so this particular heart, if you see, so what do you think? This heart is pumping. So as you can see, this heart is moving, the walls are moving, but there's hardly any kind of opposition of the walls with each other. As against this second, I think somebody needs to mute. So look at this heart. Now the valves are opening and closing, but if you look at this wall, the interventricular septum and the other wall, they are not coming close to each at all. There is a movement of the heart, but there is hardly any contraction. So even this is like, I put this figure here, that is like very obvious. And here you don't need to kind of ask what is the problem with you, because here you can obviously see that there's an X in the head, and just looking at the heart, you can say that this heart is not contracting enough. But of course, you have to kind of quantify, and quantification of heart contractility, basically all of us use fractional shortening. Then ejection fraction is another method, and third one is velocity of circumferential fibril shortening. Again, this is VCF, we don't use. And I spoke with Dr. Mohit also, we'll just concentrate on fractional shortening. So how to calculate fractional shortening? This is the most commonly used index. What you have to do is that you have to go into parasternal long axis view, get a good view and put a M mode beam just perpendicular to the interventricular septum. So this is a parasternal long axis view. Take a good view, and here what you do is that this red line. This is a. I think somebody needs to mute.
Backend people, kindly mute this. You identify where the call is coming from and kindly mute.
So this is the place where you put a M mode marker. So as you can see, M mode should be perpendicular to the interventricular septum, and then you press the M mode cursor and you will get these readings. So this is the widest diameter, that is the diastolic diameter, and this is the systolic diameter of the ventricular chamber or left ventricle, and this is the maximum width and lowest width, and then put it in the kind of equation, end diastolic diameter versus minus end systolic diameter divided by left ventricular end diastolic diameter, and the normal values are 25 to 40, and in term babies 25 to 41 will be the kind of value. So in general, if it is less than 25, then the child has got a low fractional shortening. Velocity of circumferential fiber shortening we'll skip. Again, the technique is similar. We have to get the parasternal long axis view, get this M mode image, and then you calculate different parameters, and then you put it in the. You also require left ventricular ejection time that you will obtain from the apical 5-chamber view, and then this you put it in the equation and you get the VCF. There are certain advantages of VCF, and the ejection fraction is kind of extrapolated based on the fractional shortening only. All the diameters, they are kind of cube root, and here this assumption that all the chambers in the heart, they are cylindrical, they're a sphere, and because of that there are chances of error high in ejection fraction calculation with this method. So therefore most of us will stick to eyeballing, and second important method is by fractional shortening. And the fractional shortening, if it is less than 25, we will consider that the child has got poorly contractile heart. If the fractional shortening is more than 40, it is more than normal. But if it is more than 75, think about hypovolemia as a cause of increased contractility. So now before I end, because there is no active demonstration here, so I'll quickly run through some cases, very interesting. So so this is the first case. The baby was depressed at birth and baby required 1 minute IPPR. Baby received 1 bolus. So here there was an emergency section because of antepartum hemorrhage and reduced fetal movements. The baby was asphyxiated and was shifted to the NICU after 1 bolus. Baby was on ventilator. Baby was looking pale, poor peripheral pulses. Cap refill was 3 seconds. The mean blood pressure was borderline. Baby was hypotonic, poor movements, and occasional gasping breaths on ventilator. Now here one would kind of, what is the cause of shock? Is it hypoxia? Is there any underlying sepsis, or is it antepartum hemorrhage causing hypovolemia? So immediately this baby, of course, you've given 1 dose of bolus, but whether that was enough or not, or whether you need to give more boluses. So here you immediately do point of care echo. As you can see, the IVC is collapsed and it is kissing IVC, and 1 second. I think the video is not. So yeah. So again, this IVC, the video is there, but the video is again showing that it is like a collapsed IVC. And the cardiac chambers are also hypercontractile. So if you can see, the walls are kissing to each other. So the ventricular free wall is kissing to the interventricular septum. So they are so hypovolemic. So baby received another bolus. We waited for 20 minutes, and again we saw, and basically here you know that the baby's cause of hypotension is shock, is hypovolemia. So this is second baby, and this is the kind of later on. Then after I think some time you have the dilated the IVC, which is more respectable. Now coming to the second baby, this baby is 34 week, 1.2 kilo. Mother had severe PIH. Baby is very IUGR because of that, and baby required resuscitation. Shifted to the NICU. High ventilatory requirements. Chest X-ray showed good expansion, but baby had poor perfusion and evidence of shock around 3 hours. And the blood gas was showing mixed, mainly metabolic acidosis. So what could be the cause of shock? Why the baby is requiring high oxygen? So is there any underlying pulmonary hypertension? So what will be your approach? So this is like a complicated scenario where there could be asphyxia because baby is chronically asphyxiated. There could be PPHN. There could be contractile element, maybe less. So if you see the baby's heart, as you can see, the cardiac chambers are dilated. you can see there was evidence of pulmonary hypertension. I put the probe at the tricuspid wall, and you can see there is a peak gradient of 30 millimeters of mercury. With the dilated cardiac chambers, the contracts, the fractional shorting is 0.24, and the LAO ratio is also 2.56 if you see, and the baby had a large duct. So again, this is a complicated situation where the baby has poor cardiac contractility, large duct, with evidence of pulmonary overcirculation. So this baby, again, here as you can see, the size of the duct is 4.3 millimeters. And as you can see, the IVC is dilated, distended, and hardly any contract. IVC is non-pulsatile, as you can see here. So this baby is so the ratio of minimal diameter versus maximum diameter is more than 0.5. So again, this is telling that this baby is fluid overloaded. So the baby had overall evidences that baby had dilated cardiac chamber, CCF, large PDA, pulmonary hypertension. So these were the problems in this baby. So we restricted the fluids. We started on inotropic agents. Dopamine, if hypertension is a problem, you use, and milrinone because it's like an add-on inotrope. No medical treatment for PDA at this point in time because pulmonary hypertension was there. In pulmonary hypertension, you don't treat PDA, otherwise the heart will start failing and may need treatment for pulmonary hypertension. So this is what complete picture we got in this baby, and the baby did well. Now this is something how we decide use of inotropes. This particular table is there that you can use, and this is there in our book also. Depends upon the blood pressure and the cardiac output, and you decide whether you want to use inodilator or a combination or a pressor. Now this is fourth case of sepsis. The baby was referred to us with frank sepsis with scleroderma, and baby was ventilated with 100% oxygen. Bilateral pneumonitis was there. Blood gas was showing mixed acidosis. So there was no doubt the baby has got neonatal sepsis with respiratory failure. Now this baby is showing signs of hypotension and poor perfusion. So when we did echo, as you can see, there was dilated, distended, non-pulsatile IVC. If you see the video, the baby's breath movements are there, but there is hardly any movement of the two walls of the IVC. So there's distended, non-pulsatile IVC. And if you see the cardiac chambers, the heart is, there is movement of the walls, but there is hardly any contractility of the heart. The fractional shortening was reduced to 0.2. And there was evidence of some pulmonary hypertension. There was notching in the main pulmonary, the notching in the waveform in the main pulmonary artery. So the right ventricular peak systolic pressure was 41, no PDA, cardiac output was 290. So this baby had some evidence of kind of fluid overload. There was no PDA, that was good. So baby was fluid restricted, started on inotrope, ventilation was optimized. Basically, this helps us. We wanted something to increase the cardiac contractility as well as to increase the blood pressure. So we use the combination. And this is the echo the next day. Again, this is important to visually see that the baby is improving. As you can see, the IVC has become more pulsatile now. The fractional shortening is increased to 0.3. The cardiac output has increased, and this is a known phenomenon in late onset sepsis. Even when the PDA is not there, your cardiac outputs are supranormal, and the pulmonary pressures are normalized the next day. Again, this visually you can see the the improvement and the changes, and that helps you. Again, we all know septic shock in itself is a big topic, but we know that there are a variety of hemodynamic derangements, right from preload, contractility related, cardiac output related problems, pulmonary hypertension, PDA may complicate thing, diastolic dysfunction can also be there. So all these things will help. This is the last case. Now this particular baby had murmur on the left lower cerebral border, tachycardia, and poor pulses. Pulse oximetry was normal. The baby was initially kind of 1.3 kilo ventilated, received surfactant, and day 4, baby had evidence of shock with a murmur. So we looked at the baby, the cardiac chambers appeared normal. The cardiac contractility was good, but as you can see, if you can make out here, there is a gap here at the ventricular septum. Here there is a gap. So this baby has a mal-aligned VSD. So as you can see, the VSD was about 6 millimeters. So most of the times we would consider that this baby has got a PDA and just treat the PDA. But again, we have a habit that before we treat medically for a PDA, we always do a cardiac screen, and we see that the child does not have any structural heart disease. So this baby, again, we saw there was a PDA. PDA was 3 millimeters, but it was a kind of a closing pattern. It was PDA was there, but more importantly, it was a bidirectional shunt. The IVC was dilated, and more importantly, as you can see, there was evidence of coarctation in this baby. So when you see one anomaly again you look for. So there was a mild coarctation later on confirmed by the pediatric cardiologist, and therefore no echo is complete without examination arch of aorta. When you see one anomaly in the heart, please always look for the another anomaly, and before contemplating treatment for PDA, always ensure that there is no coarctation wherein which closing the duct may land up in no problem. So functional echo helps us in kind of managing patients with identifies underlying hemodynamic disturbance, helps in planning therapy, helps in selection of correct inotrope, monitor response to therapy, and screening for structural normalcy of the heart. Thank you very much. If there are any questions, I'm happy to take.
No questions, sir. No questions in the chat box.
Okay. Are we starting with the next Dr. Mohit? Dr. Mohit, are you there?
So do we have these slides for the next presentation at the back end? Is it Dr. Sujata who has to speak?
So I think say now I think we have to start with the that is the non-cardiac. So if I think nobody's there, I think I'll start with my presentation about how to identify IVH and post-hemorrhagic hydrocephalus measurements.
I think Dr. Tushar, you can go ahead with that.
Yeah. So so let's start with the with time. Now what has happened is that we have realized that the point of care ultrasonography is not only restricted to the heart, but we are able to kind of diagnose a lot many conditions, and we can use it for our advantage. And we are using it for the brain, for the lungs, for the abdomen, and for the positioning of the long lines. In fact, we have published this in NICU practices, best NICU practices, and we call this as a fast POC USG, that is focused assessment of sick neonate with the point of care ultrasonography. So going forward with this, I'll start with this presentation, that is identification of IVH and hydrocephalus, basic measurements and grading. So as we all know, is the screen visible? I think yes, visible. So we know that which babies we have to screen for IVH. All babies who are less than 32 weeks and less than 1.5 kilo, irrespective of their symptoms and signs, we have to screen for IVH. Bigger babies we have to screen if they are sick or ventilated. So these are the babies we should screen. When do we screen them? For a baby who is less than 1 kilo, we have to screen them in the first 3 days, so as to see if there is any issue with salvageability. For stable babies, generally first ultrasonography of the brain should be done in the first week. And generally in a baby who's we are doing for IVH, the first ultrasonography is done in the so there are 2 ultrasonographies we do. So first one we do in the first week, second one we do after 7 days, because most of the IVH, 90% of the IVH will be kind of seen by about 7 to 10 days, and therefore in the first 3 days one, and second it will be 7 to 10 days. In that, if both the sonographies are normal, the next sonography will do around day 21 to day 25 to see if there is any evidence of white matter injury. But generally for IVH purpose, we do 2 sonographies, one in the first week and second week. And at the corrected age of 36 to 40 weeks, we do to see if there is any ventriculomegaly, and that has a good correlation with long-term outcome. And if there is a bleed, then that bleed needs to be weekly monitored until it is resolved or it is stable. Where to look for IVH? Now suppose we are doing point of care head ultrasonography. So we have to remember that IVH is basically happening at the site of germinal matrix, which is the site of production of neurons and glial cells during second trimester. And germinal matrix involutes between 26 to 32 weeks, where is the greatest risk of developing intraventricular hemorrhage. And why? Because these cells are at they are highly vascular, they have a high amount of mitochondria, and they are sensitive to ischemia. So when we do head ultrasonography, these are the standard 6 coronal images and standard 5 sagittal images. Here in India, we doctors do it. When I was in Australia, there used to be a technician who used to come, take these images at these specific planes, and they used to take these images to the radiology department, and the radiologist used to interpret those images at the luxury of their rooms, and they used to give the report there. So the point here I want to make is that these are the kind of standard views that we do for head ultrasonography: coronal 6 views and sagittal 5 views. So what is the site of IVH? In the coronal view, it will be seen as a lateral border of the lateral ventricle as a hyperechogenicity, and as you can see, it will be seen as a bump on the lateral wall of lateral ventricle. Now it is seen as it is here. It will be seen in the third view. So if you see, this is the third view, is the site where the choroid plexus, the caudothalamic groove is there, and generally you will start seeing presence of a bleed from the third view in the coronal plane, or the second view in the sagittal plane, where it interacts, where it goes through the caudothalamic groove. So there is another picture here, as I can show. So in the lateral view, as you can see, this is the caudate nucleus, and here is the thalamus. So here there is a caudothalamic groove. So this is the site where you will see the intraventricular germinal matrix intraventricular hemorrhage. So always when you're doing a point of care ultrasonography for the baby's brain for the IVH, always look specifically at caudothalamic groove for origin of intraventricular hemorrhage, and it will be seen as a hyperechogenic rounded opacity occupying the caudothalamic groove. Now there are different classifications. The classification which is kind of used based on ultrasonography was first Volpe's classification, and so here the grade 1, grade 2, and grade 3 were the classification, and there was a separate notion whether there is any concomitant periventricular white matter echogenicity, and that would indicate periventricular hemorrhagic infarct. And grade 1 would mean germinal matrix hemorrhage with minimal minimal intraventricular hemorrhage. Grade 2 is IVH 10 to 50% of the ventricular area in parasagittal view, and grade 3 is IVH more than 50% of the ventricular area in parasagittal view. However, studies have shown that long-term correlation wise, there are different classifications are available, but long-term correlation wise, this Papillae et al. Becomes a better modality, because there you can clearly define where exactly the blood is there. And as per the Louis Papillae classification that we use it regularly, there are 4 grades of IVH. Grade 1 is a small hemorrhage confined to the germinal matrix without effect on the adjacent parenchyma. So in grade 1, there is a small bleed at the germinal matrix at the caudothalamic groove. Intraventricular area is normal and parenchyma is normal. In grade 2, what happens is that germinal matrix bleed leaves some bleeding inside the ventricles, and so that is leakage of blood into the ventricles. However, this blood is not too much to cause ventricular dilatation. So grade 2 is germinal matrix bleeding into the lateral ventricles without causing ventricular dilatation. Grade 3 is severe bleed, wherein which there is a blood which is more, causing acute ventricular dilatation. That bleeding is so much so that the ventricles have become big. And grade 4 is the one where there is a involvement of the white matter, which is surrounding white matter extension into the parenchyma. Now later on we'll see this actually is not an extension as was previously believed. It is basically a periventricular hemorrhagic infarction which is happening because of the large bleeding which is happening at the germinal matrix site. So this classification is which is commonly used. So this is very important. We will see how each grade looks on the ultrasound images. So please follow this Louis and Papillae classification for grading of IVH. So this is the grade 1. Here, as I said, this is the bleeding which is confined to the germinal matrix at the site of caudothalamic notch, and it will be seen as a lateral on the lateral wall of the lateral ventricle. It will be visible at the site of caudothalamic groove, which is seen in the coronal view at the third image, at the third view, and at the lateral sagittal section, it will be seen as a parasagittal view, where there is a caudate nucleus and thalamus, there is a groove. So here there is a bleeding. And here always when you're doing echo ultrasonography, look at this occipital horn and temporal horn, whether it is clean. Also look at the choroid plexus. Now, please remember, when you're doing the head sonography, choroid plexus is the brightest structure inside the brain, and its brightness is equal to the brightness of meninges. Other than that, so all the brightness within the brain is compared with the brightness of the choroid plexus. Now this is grade 2 IVH. Now as you can see in the coronal section, there is a lump, there is a kind of bumpy area here on the right side. And if you see sagittal image, you are unable to see, there is a blood here. As you can see, there is some white opacity which is obscuring the occipital horn and the temporal horn. Besides that, what we have to see here is that the caudothalamic groove, there is opacity, no problem. But anterior to caudothalamic groove, if there is any collection, that indicates that there is a blood. So please remember that the choroid plexus starts at caudothalamic groove and it does not extend anterior to choroid plexus, anterior to that groove. So if there is any hyperechogenicity you are seeing anterior to choroid plexus, it is generally the bleeding which has happened. So this baby has grade 2 IVH, and there is no dilatation of the ventricular system, and the blood gravitates in the occipital horn. So again, this is very important. Suppose there is a doubt whether there is any blood in the occipital horn. So what you can do imaging through the posterior horn. And in the posterior fontanelle, if you put a probe, you will be able to see the occipital horn and you will be able to see if there is any blood collected there. This is the long axis or sagittal view from the posterior fontanelle, and this is the coronal view. Again, you are able to see both the posterior horns as well as this is the occipital horns of the lateral ventricle. Now this is grade 3. Now as you can see, there is a bleeding which has happened there, and as you can see, the diameter is kind of huge, that is shifting the midline to the other side, and there is a dilatation of the ventricle. It is filling the ventricle and dilating the ventricle. If you see the periventricular white matter, there is a normal echogenicity, and the other ventricle has dilated because of the pressure effect. So the bleeding which has happened on this left side is grade 3 IVH. And on the parasagittal view, you would see a C-shaped cast which has happened in the cavity of the lateral ventricle. Now coming to the grade 4 IVH. Now, as I said, grade 4 IVH, if you see pathophysiologically, it is slightly different than grade 2 and grade 3. Previously, the thinking was that when the bleeding is small, it is grade 1. When the bleeding is little bigger, it is grade 2. When the bleeding is even little bigger, then it is grade 3. And when the bleeding is so much bigger that it involves white matter, it is grade 4. However, now we know that that is a misnomer. That grade 4 IVH actually is not related to grade 2 and grade 3 IVH. Grade 1 IVH, which is confined to the germinal matrix, can directly complicate into grade 4 IVH rather than going to grade 2 and grade 3. Grade 2 and grade 3 are related to bleeding which is happening within the lateral ventricles. If it is small, it is grade 2. If it is large, then it is grade 3. However, if the bleeding which is there in the germinal matrix, it obscures something called as terminal vein, which is draining the periventricular white matter. This periventricular white matter is drained. This periventricular white matter is drained by this terminal vein, and which this terminal vein goes through the germinal matrix. So any bleeding which happens in germinal matrix is compressed upon this terminal vein, and that would lead to hemorrhagic infarct in this periventricular white matter. And therefore, it looks like a bright structure. It is not a hemorrhage technically, it is a hemorrhagic infarction which is happening because of the blockage of this terminal vein. Same thing from the parasagittal view. If you see, this is a terminal vein which is kind of happened because of the joining of medullary veins which drain the periventricular white matter, joining the choroidal vein. Medullary vein and choroidal vein join together to form the terminal vein, and terminal vein has to run through the matrix of germinal matrix, and there, if there is a pressure effect because of the bleeding, that will obstruct the vein and will cause a fan-shaped infarct, as you can see here in the periventricular white matter. As you have seen that there is no dilatation of the ventricles, so there is no grade 2 or grade 3 here. Here there is a direct grade 4 IVH. So we know that I'm not going into detail of their outcomes, but we know that grade 1 and grade 2 IVH outcomes are fairly acceptable, but grade 3 IVH 3 and grade 4 are fairly not acceptable. Generally, they will have long-term morbidity and long-term neurodevelopmental issues. Studies have shown that some babies have grade 1 or grade 2 IVH. However, along with that, there is a white matter injury also, which is sometimes not seen on the sonography, and that one has to unmask with the help of a MRI, and that would give you a better prognostic indicator. So generally, just based on this, we can derive some assumption, but it is many times inaccurate. Now coming to the post-hemorrhagic hydrocephalus, the second part of the chapter, and this post-hemorrhagic hydrocephalus is a complication happening because of the bleeding which happens within the lateral ventricles. Once that bleeding happens, that bleeding can go into the foramen of Monro and other foramina, and they can block the drainage of the CSF and lead to hydrocephalus. I have to thank Dr. Pradeep Suryavanshi, because this part of the presentation I have taken it from him, and acknowledgements to him. So basically, hydrocephalus is dilatation of the ventricular system due to increase in CSF volume, and it is not only volume but also pressure. We know that the CSF is mainly produced by choroid plexus, and it is absorbed by arachnoid granulations which are there on the surface of the brain. So what happens when there is a large IVS? There is multiple small blood clots which clog up the channels of reabsorption of CSF, and later obliterative arachnoiditis. There is initial period of reduced CSF production, but when CSF production returns, the lateral ventricles enlarge. The progressive accumulation of CSF changes the shape of the lateral ventricles from slit to a balloon. So normal CSF pressure does not exceed 6 millimeters of mercury. As the preterm skull is very compliant, the ventricles can expand without pressure rising initially, but eventually pressure can also rise to 10 to 15 millimeters of mercury. Thus, PHVD, that is post-hemorrhagic ventricular dilatation, may produce progressive ventricular white matter injury over several months as a consequence of pressure, distortion, free radical injury, and inflammation to a brain which is still not fully developed and mature. So how to do the assessment? Again, the standard 6 coronal views and 5 sagittal views. The view number 3, again, is very important as it goes through the foramen of Monro, and it goes through the third ventricle. Also, we describe it as Trishul view. Indians will call this a Trishul view. As you can see it like a Trishul. And in this view, you will see the lateral ventricles, third ventricle, and the foramen of Monro, which kind of opens the lateral ventricle to the third ventricle. So normally we have to remember that lateral. So what is the normal shape of the lateral ventricles? The lateral ventricles are normally concave in shape, and their size is generally less than 1 millimeter, less than 10 millimeters. So preterm neonate, natural variation in the ventricular size, asymmetry of the ventricles is common, and the left ventricle is normally large. So suppose you see something like this as shown here, and rest everything is normal. Don't worry, this baby doesn't have hydrocephalus. This doesn't have ventriculomegaly. This is a normal variation where the left ventricle is slightly larger. In a full-term baby, again, be wary of diagnosing cerebral edema, because in full-term babies, normally in sagittal and coronal views, the lateral ventricle is very difficult to view, and it will be seen like a slit-like. So when you diagnose cerebral edema because of this, you have to also see how is the sulcal and gyral pattern before kind of calling this as a cerebral edema. So we have to always remember that in the full-term baby, the ventricle is very small in size anyway. Now coming to the hydrocephalus and hydrocephalus ex vacuo. Now what I said initially is that basically hydrocephalus is a situation where there is more fluid and more pressure. So pressure is very important, as against in ex vacuo, where in which there is a damage to white matter in the brain, and because there is damage to the white matter, there is a less brain substance, and because of which the ventricular system is dilated. So how do you kind of decide whether it is because of this or because of that? So we have to see the lateral wall of lateral ventricle. So as you can see in lateral wall of lateral ventricle, here as you can see, this is ex vacuo, because the shape of the lateral wall of lateral ventricle is maintained. Okay, there is no pressure effect. So suppose if there is increase in pressure in this CSF, what will happen? It will push like this. Okay, so here the pressure effect is there. The ventricular wall is being pressed by the increase in CSF and pressure, and therefore this is hydrocephalus because of increase in fluid and increase in pressure, and as against here it is a X vacuum. Also, second important clue whether it is X vacuum or because of hydrocephalus is the presence of periventricular seepage of CSF. As you can see, in the periventricular area there is a seepage of the fluid. The lateral wall is convex, convexity of the lateral wall, and then there is evidence of seepage of the fluid in the periventricular area that would indicate that there is a hydrocephalus. So progressive ventricular dilatation usually occurs over a period of 1 to 3 weeks after IVH, and that is the reason that when you have a grade 2 or grade 3 IVH, every weekly you do sonography to see whether there is increase in the IVH, whether this increase in whether there is setting of a hydrocephalus. So rapidity of increase in the hydrocephalus is related to the severity, and here clinically you will see increase in head size, full anterior fontanelle, sutural separation, and posterior horns dilate earlier than anterior horns. So usually on day 8 of life will be like this. Day 11 it will be complete dilatation, as you can see, and day 15 of life there will be further dilatation, and it will be complete dilatation of all the horns of the lateral ventricle. So how do you diagnose PVHD and quantitative measurements? So these are the various things which we do. So some first is ventricular index. So what is ventricular index? It's basically known as Levin's ventricular index because he's produced the reference ranges according to the gestation age. So what do? You do the measurement from the falx to the lateral wall of the body of the ventricle. So this is the falx. So this is A, and so basically this point to this point is the measurement. So ventricular index is from the falx to the lateral wall, and this measurement there are charts. So this is on the right side, this is on the left side, and then there are ventricular index charts are there. So what happens that this dark black line is the average ventricular index for a postnatal age, and depending upon the gestation of the child, there are kind of upper limits. So at 28 weeks is 10 millimeters, 30 weeks is 10.5, and like that, so on and so forth. If the size of the ventricles is above this, then there is a that is abnormal basically. And what is the action line? It will be 4 millimeter over the 97th percentile for the ventricular index. That is the time when you should intervene. Now I have to say here is that basically that these lines and these recommendations are fairly old, and these recommendations nowadays we do not wait for the ventricular size to increase and go 4 millimeter beyond 97th percentile so as to intervene. What we do is that we do a Doppler and see if the increase in pressure is affecting the blood circulation in the brain. If it is affecting, then that is the time to drain the CSF and reduce the pressure. So sometimes ventricles do not expand laterally, and they become rounded but expand occipitally, anteriorly or occipitally. So therefore, a combination of 3 measurements are taken: anterior horn width, thalamo-occipital distance, third ventricular width, and fourth ventricular width and length. So only Levin's index is sometimes not enough, and we also take the diameter for other places. So this is anterior horn width. So the maximum diameter of the anterior horn in the first or second coronal image, and that more than 4 millimeter is a kind of a warning, and if it is more than 1 millimeter above 97th percentile, then that is the action line where you need to drain. So again, anterior horn width is normally 1 millimeter, and if it is 1 millimeter above that, along with the signs of hydrocephalus, then you need to drain. And so again, there are nomograms available, and how to measure, that is important. The widest diameter you have to take and take the measurements at that place. Now coming to the second one is a thalamo-occipital distance. So first we saw Levin's index, second we saw anterior horn width, third we are seeing the thalamo-occipital distance. So go to the sagittal view, anterior fontanelle, and take a proper midline view. Take a first midline view and then go to the parasagittal view, and in the parasagittal view, as you would see, there is a caudate nucleus, thalamus, and this is the posterior body of the thalamus to the occipital cortex. So this is the thalamo-occipital distance. Now this distance normally is to the tune of about 25-26 millimeters. If it is more than that, then it is abnormal. Again, there are gestation-based nomograms, and there are 97th percentile and 3rd percentile on both sides, which are published. So action line is if the distance is more than 26 millimeter, or if the distance is 1 millimeter above 97 percentile, then that is the time you have to take the action. Then third is ancillary measurement is third ventricle width. Now third ventricle is visible in the coronal view, in the third coronal view, and there you measure the distance from wall to wall. And if that is not possible in the coronal view, you can take the mastered view also, where in which you put the long axis probe behind the ear, and you try and get the third ventricle and measure the width. So third ventricle width is again less than 1 millimeter always. If it is more than 3 millimeters, then it's action line. There you need to reduce the pressure. So definition of PHVD is if the anterior horn width is more than 4 millimeter, if thalamo-occipital distance is more than 26 millimeters, if third ventricle width is more than 3 millimeters, and measurements on both sides must exceed these limits for us to call it as PVHD. PHVD. Then coming to the fourth ventricular width and fourth ventricular length. Again, so we have to go to the mastered view, and there you will be able to identify the fourth ventricle, take the measurements of length and width, and again there are nomograms there, and you can decide whether the baby is having hydrocephalus there. So if you look at the natural history of post-hemorrhagic hydrocephalus, almost 25% they slowly progress with ventricular dilatation, 25% will have non-progressive ventricular dilatation, and 50% generally would resolve. So therefore, these 25% are the ones who would require further therapy in terms of the drainage of CSF or sometimes shunt surgery. So again, I'll skip this. Generally after there is a hemorrhage, we have to monitor the baby's head growth. If the head growth is more than 1.5 to 2 centimeter per week, it may signify rapid progression, and severity of initial IVH is the most critical determinant of evolution and course, and management will depend on clinical course of post-hemorrhagic ventricular dilatation. Now, another important aspect nowadays, how we go about doing the drainage of CSF or to relieve the pressure in the ventricular system in situation of post-hemorrhagic ventricular dilatation or hydrocephalus is based on the Dopplers. And now we believe that these Dopplers will affect once the pressure goes up before causing stretching on the long tracts and causing complications. So what we do is that this is the anterior cerebral artery, and we do the Doppler there, and we calculate the resistive index. If the RI in the anterior cerebral artery, the normal values are 0.9 to 0.5. If the value is below 0.5 or above 0.9 are abnormal. So in a situation where there is increase in pressure intracranially because of hydrocephalus, the diastolic flow gets affected, and therefore the RI more than 0.85 or 0.9 suggests decrease in diastolic flow because of raised ICP. And here in this situation, if you put slight pressure on the anterior fontanelle as you're putting the probe, the diastolic flow even stops or becomes negative. So that is the sign that there is a raised intracranial pressure. So again, this will be indication for tapping. But here we have to remember that we rule out hemodynamically significant PDA. Dr. Pradeep showed in his talk that if you have a PDA, which is a hemodynamically significant PDA, there is reversal of flow in aorta, and there is reversal in flow in the middle cerebral artery and anterior cerebral artery. And here you may mistake that the reversal of flow which is happening is because of hydrocephalus. So it is not. So when you decide about tapping, you have to ensure that there is no PDA, and still there is absent or reversal of flow in the diastole, in the middle cerebral artery or anterior cerebral artery, then it is an indication. Now, as you can see, sometimes these babies may require 25% of they may kind of arrest this hydrocephalus. You do the serial tapping and it will arrest. The effect of fontanelle I want to show here. If you put the probe on the fontanelle, initially, as you can see, the diastolic flow is kind of absent or very little. And once you put the pressure, the diastolic flow will start becoming negative. So you have to slightly increase the pressure, and that will increase the become the flow negative. So this is actually wanted to show, just to summarize this particular talk. Basically, when you're looking at intraventricular hemorrhage, look at the chordothalamic groove. The chordothalamic groove you will be able to see in the coronal image at the third image and in the parasagittal view. And the intraventricular hemorrhage starts at that place and then extends either into the ventricle as a grade 2 or grade 3, or it can block the terminal vein and can lead to periventricular white matter injury. So there you have to see the IVH and the post-hemorrhagic hydrocephalus, the various indices which I told you. First one is the Levin's index, the second one is anterior horn width, third one is third ventricular width, and the thalamo-occipital width, and then you come down to the fourth ventricular dimensions. The Doppler is changing the way we are managing post-hemorrhagic hydrocephalus, and most of these 50% they don't progress, 25% they settle down, but 25% of them may require shunt surgery. And I can see Dr. Pradeep, as I said, these post-hemorrhagic hydrocephalus slides I have borrowed from him. So a big thank you. And this completes my talk. And if there are any questions, then I'm happy to take.
So there is one question from Dr. Amar Singh. What is the role of RI in predicting prognosis of HIE?
Yeah. So hypoxic ischemic encephalopathy, there is a cerebral edema most of the times. And the second important aspect which happens with HIE is that the circulation within the brain becomes pressure passive, because there is a loss of vasomotor regulatory tone in those blood vessels. So generally what happens is that the RI goes down. So in a situation, in a situation of asphyxia, if you have RI value less than 0.45 or less than 0.4, it tells you that the baby's brain is significantly affected, and these babies have a poor long-term neurodevelopmental outcome. So it's a very good question. We routinely do RI. Generally, when we refer these patients to our radiologist, we'll just do head scanning and report there is a cerebral edema. But when we ourselves do, besides cerebral edema, we also want to know what is RI, because that gives us additional information whether the baby is going to have a better or bad long-term neurodevelopmental outcome. Thank you.
Okay. If there are no questions, I think we will start with the next session. That is on the cranial ultrasound presentation. So we'll be going to the very basics about the cranial ultrasound. In this lecture, we will see the importance of the cranial ultrasound, various views of the cranial ultrasound, and already Dr. Tushar has covered about the IVH and post-hemorrhagic hydrocephalus. So these are the basic aspects about the cranial ultrasound. From the clinical perspective, we are going to discuss. And I think the second aspect has been covered. So we know that the cranial ultrasound is very, very useful modalities in the ICU. Since 1980, ultrasound is a part of the bedside system into the most European countries. And in India also, now since 2005, we all are using cranial ultrasound as our day-to-day practice. As we all know, this is a point of care test. It is very important imaging modality, and it is very reliable modality. We know that we don't have to ship the baby. It is a thermoprotected environment, no need of radiation, and it is very diagnostic and prognostic value. And most important is not expensive as compared to CT scan and MRI. And hence it is a very suitable for the screening modality. So why we say this point of care ultrasound is a bedside, which is a point of care, because this is a focused. We know the question and we have to give the answer. It is a bedside one. It gives a real-time picture to us. It is a serial one. It is mainly for the function. It understands the physiology. It is useful for the decision of the definitions or functions. And then we target the treatment. And that's why we monitor the responses by these point of care ultrasound systems. What is our aim from the cranial ultrasound? Basically, our aim is to find out any pathology, timing of injury, prognosis, and treatment options, what we require from this one. Now, we have important here which transducer to use. So ideally, you should be having a good sector probe, which is from 8 to 12 megahertz, which is ideal. But if you have also the linear one, then it can be around 12 linear one, sometimes, which is useful in the big babies. But probably I would say that sector 8 to 12 probe is a reasonable one, which is good for us. Because if you see If I use the sector scanner, then that is how it acts as a kidney level. While the linear scanner, it is useful in cases of scanning the various parts. So remember, for doing the cranial ultrasound, anterior frontal we use, and for that anterior frontal, the sector scanner is the one which is the most useful from the perspective of our outcome. Always consider Acipswzb precaution, and important is the jelly. So jelly acts as the a medium between the transducer and the machine and the baby, so which is very important. I already mentioned for the good machine, you should have a standard a sector which is a phase arrow probe which is from 8 to 12, then it is a good. If the baby is a large baby with a thick hairs, then probably 5 to 7 megahertz probes are useful. Equipment protection is important. Falling of the transducer. One more thing we have to be very careful. Jellies, they attack the rats, so you have to have a clear-cut storage cleaning policy in the ICU. Always be careful about hypothermia and asepsis in such babies when you are doing ultrasound. Just to have when you are going to do the ultrasound, first important screening purposes for your IVH, that is if the baby is less than 28 weeks, first 24 hours, within 72 hours, first week, second week, 4 weeks, 6 weeks. If the baby is between 20 to 32 weeks, at least one scan in the first week and second scan before discharge. In cases of HI, to find out cerebral edema, find out the RI, just we discussed. When the baby deteriorates on the ventilator, when there is a deterioration of neurological state, a baby with the seizures, follow up with the post-hemorrhagic hydrocephalus, and babies with apnea, bradycardia, and baby looking sudden pale. These are the conditions where we are going to do the cranial ultrasound at the bedside. We have a standard approach, mainly through the anterior frontal. We also have supplemental windows, which are through posterior frontal, mastoid and temporal windows. So, most important, we record 6 standard coronal and 5 sagittal planes. These are the ones what we at present moment record in these ones. We have the coronal view and the sagittal view. That means we put a probe coronally and take the anterior frontal 6 views, and then we put a probe sagittal, and then we take the sagittal 3 views, which is the parasagittal right and left, and then midline sagittal. For the transducer, where to keep? For the coronal, the notch of the probe should be on the right side. So remember, this is the notch. It should come on the right side of the baby. That is the most important aspect. While in cases of the sagittal view, the notch should be forward, that is towards the nose. So notch towards the nose is the one accepted or important norm in cases of the sagittal views. If you see now, we'll go through the various views, that is a coronal sagittal views, which are the commonly used in cases of cranial ultrasound. So coronal, that is I told you we take 6 planes. The first plane is called as through the frontal lobe. So this is the picture, that's a notch, and the coronal, how to keep the probe, that is what the coronal view. So when you put the coronal view, now you are sweeping from anterior to posterior in the coronal. That is the most important aspect. So this is a sweep from anterior to posterior to get coronal ones. So the first coronal goes through the frontal lobe. Second, the frontal lobe of the brain. The second view goes through the frontal lobe of the ventricle. Third view goes through the midline of the ventricle. Fourth view goes through basically the lateral ventricles, the most midline part of the lateral ventricles, and then the posterior part of the lateral ventricles, what we go through. So when we put a probe anteriorly, so this is called as the frontal lobe. In that frontal lobe, we will see that the picture that we will see the frontal lobe of the right side, frontal lobe of the left side, and this is the midline. This is the midline interhemispheric fissure, while this echogenicity picture is the orbital reach. Below the orbital reach, we will find orbits. So this is a classic picture of first view, first coronal frontal lobe view. When you pass through the second, that is called as the frontal horns of the lateral ventricle, which is anterior to the foramen Monro. That is the second view what we usually go through. So in the second view, you cross to the frontal horns, and the basic part of the white matter and gray matter you cross. So how the picture looks like on the gray scale in the ultrasound, you will see the midline, that basically echo-lucent structure, which is called as cavum septum pellucidum. Both sides you will see the lateral ventricles. This is the CSF. So this echo-lucent structure is the CSF, which is occupied in the lateral ventricles. This is the frontal horn of the lateral ventricles, and the area which is adjacent to the cavum septum pellucidum is the area of the basal ganglion. The structure which is anterior to the cavum septum pellucidum is a corpus callosum, while the midline structure is an interhemispheric fissure. And you will be able to see the temporal lobe also. And this is the second view, what we called as a frontal horn of a lateral ventricle anterior to the foramen Monro. The third view is through the actual foramen Monro. So we will see the third view, which is actual to the going through the foramen Monro. How it looks like? It looks like this view is called as the Trishul view. So in India, it is like a Trishul of the god, and that's why we call Trishul view. The lateral ventricle acts as a part of the Trishul, while the foramen Monro is the joining part of lateral and third ventricle. So on the gray scale of ultrasound, how it looks like? Can you see these are the lateral ventricles, third ventricle, and you can see here the third ventricle, while you can see the aqueduct of Sylvius, while interhemispheric fissure in the midline, brainstem, internal capsule, thalamus. These are the other structures we can able to identify. Cavum septum pellucidum and corpus callosum, they are there. So most important part of this view is that you could able to see the lateral ventricles and third ventricles as a tissue-like a structure. So this is what which is more picturized. You can see this is what the blue color, which are the lateral ventricles, then foramen Monro and third ventricle. This is called as the trishul. The structure superior and anterior to this is your corpus callosum, and in midline, which is a green color here, is called as the cavum septum pellucidum. These are the major structures what we identify into the mid-ventricular foramen Monro view of these ones. Posterior to the foramen Monro, we will be able to see the lateral ventricles with the choroid plexus, and the choroid plexus looks like echogenic structure. So when you see these echogenic structure, these 1, 2, and 3, these are the 3 white dots you see, and hence this area is called as lateral ventricles with your choroid plexus, and that's what we called as a 3-dot view in these ones. If I go more posteriorly, I am mainly cutting through my choroid plexus, and it looks like that you can visualize the choroid plexus very well. So this is a proper choroid plexus you can visualize in this view, and this is called as, actually we call this is a trigone view. So the echogenic structure is a choroid plexus. In between this echolucency structure, which is a CSF in the lateral ventricles, and this whole structure we call as a trigone, and hence it is called as a trigone view. Along with, you could able to see occipital and posterior temporal and occipital lobe of the cerebrum. Once I go more posteriorly, that is through the white matter. There is no ventricles in that view. So this is the view where you will see only white matter and no ventricles. And this view is also useful to find out the injury about occipital injury, which occurs because of hypoglycemia. You could also see the PVLs because of ventilation, hyperventilation structures. Now go to the sagittal views. In the sagittal views, now, which is a second plane, that means we are keeping a probe in midline sagittal. So in this midline sagittal, if I put a probe, naturally, my probe is towards this range, that is towards the nose. This is my transducer notch, and I'll be doing the probe is in the midline, right side or left side. This is called as midline sagittal. If I go to right side, which is called as right parasagittal. If I go to the left side, which is called as left parasagittal. So that's notch I told you, and I told you about the midline sagittal, right parasagittal, view 1 or view 2. Sorry, this is left, and then the right and left, right 1 and 2. What it looks like, you put a probe in the midline and you will be able to see the structures which are in the midline. These are, so when I put a structure in the midline, I could able to see the midline structure, which is a cavum septum pellucidum. This cavum septum pellucidum, which is capped by corpus callosum. So superior to your cavum septum pellucidum is a corpus callosum. You can easily identify the singular gyrus here. The structure which is superior to the corpus callosum is a singular gyrus. While you will able to identify a good, you could able to identify a good third ventricle and fourth ventricular in this view. While you could able to see a good flow about the CSF when you actually do the image. This image is called as a lady in dress view. So if you cover this ventricle plus the part of the cerebellum, this is a cerebellum, this is a fourth ventricle, and this is cerebellum vermis. If you design this part, it looks like a lady in dress view in the European country. That's how the lady in dress view, and hence it is called as the lady in dress sign or lady in dress view as a midline sagittal view. So this is how it looks like. Can you see the third ventricle, fourth ventricle, cavum septum pellucidum, corpus callosum, and then there is a surrounding above which is image which is captured. If I go to the parasagittal, my ventricle is fully exposed in the parasagittal. Ventricle has a parts, frontal part of ventricle, body of the ventricle, trigone of the ventricle, occipital horn of the ventricle, and temporal horn of the ventricle. These are the various parts of the ventricles I can able to identify in parasagittal ventricular view. At the same time, I will also able to identify the cerebral structures which are basal ganglion structure, and these are the caudate nucleus and thalamus. And this is the best view to see the caudothalamic groove. This is the caudate and this is thalamus, and this is the caudothalamic groove. And you should able to identify your bleed in this caudothalamic groove. So this is the caudothalamic groove. So how it looks like? Can you see this is the caudate nucleus, this is the thalamus, this is the caudothalamic groove, and the ventricles. This is how the structures look like. And if I see the grayscale, the ventricles is fully, I can able to see frontal horn of the ventricle, body of the ventricle, the choroid plexus of the ventricle, and the occipital horn, along with my temporal horn of the ventricles with the choroid plexus, caudate nucleus, and thalamus. This is a caudothalamic groove which we could able to see. Now, if I go more towards the parasagittal, then I would be able to see only the white matter, no ventricles and only white matter. There are some axial views. I will not go into the depth of these axial view, but these axial view are also useful for some time. And these axial view are mastoid, temporal, and the one which we could see here is the mastoid, which is useful for visualizing all ventricles, mainly fourth ventricles, which is useful to diagnose the non-communicating and communicating hydrocephalus. That's how you could able to see the heart, which is in the lying down posture. And in this axial view, which is mastoid, can you see these lateral ventricles? You will see third ventricles and the fourth ventricle. If your fourth ventricle is dilated or only third is dilated, lateral and third dilated, that means the block is here. If fourth is also dilated, that means the block is below the fourth ventricle, which you could able to diagnose. And this is how you could able to see the aqueduct of Sylvius. You could able to see the posterior chambers of these ones. Now you can see here, this view is also useful to see the circle of Willis. This view is useful to put a Doppler in the middle cerebral artery. That's very important when you consider the RI in babies with dyspepsia RI in babies with the PDA, this view is also very, very useful. Then if I go to the most posterior, that is the basically the temporal part, which is basically useful for finding out cerebellum. So if I go post auricular, this is my cerebellum. This is my cerebellum. And I could able to diagnose the cerebral hemorrhage, cerebral infarct by post auricular view. This is very important view for babies who are ELBW. Nowadays you see less IVH, but you could able to see more posterior view, and you can able to diagnose cerebral hemorrhage. The babies who are less than 428 weaker, 37% of the babies will have cerebral hemorrhage. So those people who are monitoring level 3 care, cerebral view is very important. That's how this is how you can see the cerebellum, and that's how cerebral hemispheres with the bleed. This is the whole ventricle also. There is a posterior frontal also, but I will not go in depth about that. That's very simple. In the posterior frontal, you could able to see the ventricles and the one part. These are the articles written by our team: neurosonography in the neonate, point of care neonatal ultrasound, and these are the guidelines and guidelines written by our team: cranial ultrasound in the newborn. Those who are interested, they are available freely on the net. You can go and download these ones, and that you will get all the information about the neurosonography of the neonate. This is the book written by our team, Atlas of Point of Care Neonatal Cranial Ultrasound. Those who want, they can send SMS to my WhatsApp. We will try to arrange for you about this book. So I think with this, I will stop here the presentation, and I will hand over to Mohit sir. Mohit is here now.
Yes sir.
Okay sir.
सर वो IVH वगैरह का हो गया क्या?
Yes, yes. IVH post hemorrhagic hydrocephalus हो गया है. Tushar sir has taken that.
Okay.
Yeah.
So in next 20-25 minutes, we will see what others, like we have seen what we can do with heart, and the other major organ is brain. So we have already seen that the normal views and IVH and hydrocephalus, what we can do. So there are but other areas also. So we'll just touch upon it because it's not very extensively. We cannot do that. So we will just touch upon that, and let's see where all other areas where we can use our ultrasound probes. Okay, are you able to see my slides?
Yes, sir.
Okay, fine, sure. So which are all other places where we can use the head ultrasound? One we have seen heart, we have seen brain. So one other organ is lungs, but there are all other things we can do with this. So let's start with one case. This is 19 days old male born to 29 weeks gestation, 1 kg, having hemodynamic significant PDA. For surgical ligation was referred to level 3 as failed 2 courses of medical closure, who are having E. coli sepsis, bilateral IVH. Very significant lung disease on high frequency F5 to 40%. Procedure was done, PDA ligated, went uneventful for 52 minutes. But then after the ligation, you see the blood pressure started falling. Was started on dobutamine. The oxygen requirement went up. So his mean airway pressure requirement went up. pH became acidotic, lactates kept on increasing. But after this, little hard. This is when the echo was done. Even on dobutamine and of 20, the blood pressure was low. But after this, it went up. So does that mean this doing an echo increases of blood pressure? No. But doing an echo, this was an echo which was done. And as you can see, there was a pleural effusion. So that was hampering his cardiac outputs. So as soon as this pleural effusion was being taken care of, chest drain was inserted, the baby became well. So it is not always the heart we should concentrate. It is around the heart also. It is very important. So clinical assessment is important, but sometimes alone it cannot work. So we should have to go in hand with the ultrasounds. Okay. So which all places we can use our ultrasound machine? Head ultrasounds you have seen. We can use it to see the pleural effusion, ascites, like to see directly and tap the bladder under ultrasound guidance, put in the long lines and then see the central line tips. And then many papers have been published in which it is being very sensitive and specific method to see and confirm the ET tip. So you can prevent the babies from getting an X-ray done to diagnose the pneumothorax and other conditions ultrasound. Sometimes you tend to get the ready-made thing in front of you. You easily come and start eating. But we never think that how this thing was being made. Okay, so it is very important to go to the basics of everything, how the things are started. So it is not only the clinical and ultrasound, it goes in combination. You have to go till the root cause. So just see, this is the pleural effusion. So where you have to keep the probe. The probe has to be in the lateral, like in the anterior axillary line. You do the probe and this is what you will see. And this is where you will look for the pleural effusions. You can diagnose pleural effusions. Ascites, it has to be lateral. You have to be lateral in the abdomen. Okay. And this is how, see, this is spleen. And all around there is a ascitic water. So you can quantify the ascites also. For bladder, it is just above the anterior and pubic line. So bladder, if it is rounded, it means it is completely filled. If it is hexagonal, it is just filled. It is not distended. So you can even tap under ultrasound guidance. Endotracheal tip, you have to do what we say as arch view. So this is what I showed you in the views, arch view. This is the arch view. And where you have to look for which is this is the first branch, second branch, third branch. So you will see the ET tip. Here you are seeing that ET tip. It is in between the first and second branch. And the ET tip, like this one, this is the ET tip. This distance along from the outer wall of the arch, that should be minimum around 1 centimeters, 1 to 1.5 centimeters. It is less than 1 centimeter, then it is more in, and it is above 1.5 centimeter, then it is out, like it is not at the carina. This is how we judge that whether the ET is at place or not. And for the vascular access, you need to have a high frequency probe. This is what we call as hockey stick probe. And this is for the femoral. So this is cross-sectional. When we have kept, you can see the femoral artery and vein. And then you assess which is the femoral artery and vein and put the under direct ultrasound guidance. You can put in take the central line, femoral vein. Similar thing you can do, it is in longitudinal view. As you can see, it is at 12 o'clock. This is how you will see the vein. And then ultrasound guided, you can directly poke in the vein and put the central line in. Similar for the internal jugular. You have to put it in the neck, lower 1/3 and upper 2/3. And again in cross section, you will see vein and artery. You need to know the anatomy, which is medial, which is lateral. And for UAC tip and UVC tip, you have to do just subcostal longitudinal view. And this is how you will see. See very well, you can see the UAC tip. This is abdominal aorta and this is the UAC tip. Okay. So the tip, ideally the tip, when we say it should be, ideally the tip should be when this descending aorta, it starts. So it should be around 2 centimeters. Okay. Around 1 to 2 centimeters below the third branch of the aorta. So that will correspond to your T4 to T6. And for internal jugular lines, you have to see the high parasternal view. This is for the SVC. And this is how you will see the SVC. This is how you will see the SVC, but I would skip this. Oops. So that was regarding the central line tip, how to see and to insert. I am just trying to touch and go. Another important organ which we tend to see with these ultrasounds is lung ultrasound, and it is coming up in a very big way. We'll discuss only main things. We won't go in detail because it needs half-day workshop for this. So why the lung ultrasound is there? Because it is easy, very easy. If you start doing it, you will find it. It is bedside, faster, real-time evaluation, and the studies have proven it is high specificity and sensitivity. It prevents the baby from radiations, and pneumothorax diagnosis sensitivity is very high. So you can use this, and then you can make diagnosis, whether the fluid is there, whether the lung is collapsed or inflated. And basically, these are artifacts which have been used as signs in the lung ultrasound. Mostly we use linear probes, that is high frequency probes, but you can use curvilinear or phase array probes also. But minimum, you should have a frequency more than 8. Mostly we use 10 to 12 hertz probe for doing the lung ultrasound. Okay, and area, like this is adult, they're divided in 6, but in newborns we divided in 4. 1 sector, 2, 3, and 4. This is in the sternum, this is anterior axillary line and mid axillary line, and then you draw this at the nipple line. So there are 4 sectors where we should see. So normally these are skin tissues. You will see a rib, and then you will see few lines, A lines, B lines, what we call. I will just show you. So this is a lung ultrasound which is being done. This is with the linear probe, and this is with the phase array sectoral probe. This is a rib. This is a pleural line, and this is very important to recognize because for the normal lung functioning, we see for the lung sliding sign, and that is what the pleura is rubbing along over the lung. And then we have these A lines, horizontal lines. Okay, the pleural line is very important to recognize lung sliding. Okay, so this is, as you can see, this is a diagrammatic presentation. This is pleura. This is a pleural line, and these are the A lines, these things. So as you can see, this is pleura, these are A lines, and this is the rib shadow. And then we have B lines. The A lines were horizontal, these are vertical. Okay, if you have very fluid filled, congested lungs, then you have very crowding. We even called rockets. So if you have congested B lines, they are called rockets. But normally, if it is not fluid filled, not congested, you see 2 or 3 in one frame. So these are your B lines. These are for the normal lung. As you can see the lung sliding, this is the video. You can see this moving pleural line. So this is what we call as moving pleural line as lung sliding. It is absent in pneumothorax. And when we do the M mode of that, we get this kind of picture, what we call as seashore sign. That is means the pleura and the lung tissue is there and there is no pneumothorax. And so this is how you can, this is fixed M mode and this is a running M mode video. So this is how it is look like as sea water and beach. So that's why it's known as seashore sign. If it is a pneumothorax, okay, then it is what we call a stratosphere sign or the barcode sign. This is how it will look like in pneumothorax. Okay, so if you have, especially it is more easy to appreciate in adults, not in newborns. You have a pneumothorax here and normal lung here. So if you do the ultrasound over this section, here you will get seashore sign, here you will get a barcode sign. And this point is known as the lung point sign. And it is very much diagnostic of and specific of pneumothorax. So in pneumothorax, if you do an ultrasound, there will be absence of lung sliding, absence of B lines, absence of lung pulse. It won't go in. Just if you have absence of lung sliding sign, absence of B lines, and you get stratosphere sign in M mode, it is diagnostic of pneumothorax. As you can see in this, you can see lung sliding here, but lung sliding is absent here. So that is the pneumothorax there. Okay, this is how we are doing the ultrasound. So you will get lung point. This is a lung point. So this is normal lung, seashore sign. This is pneumothorax. That is stratosphere sign. Okay. And then in consolidation, this thing you get shredded, like shredded cotton, shredded clothes. You will get this kind of fluffy shadows in for the lung. So that means there is consolidation. It is more likely for pneumonia. And if you get very crowded B lines like this, it means there is a lung congestion, like in very bad TT and in RDS, as you can see, this is severe RDS, and this is RDS after giving the surfactant. So you can diagnose if your lung is like this, okay? So and the baby is premature, so it coincides with your severe RDS. You give surfactant and repeat the ultrasound, you can see the changes in ultrasound. So this is something which is very good. You can clearly note immediately. So in the end, the take-home points are, the point of care ultrasounds include cardiac ultrasounds that we have discussed. We can see the structure, pericardial effusion, cardiac output, everything. Then cranial ultrasounds, especially for IVH IVH and hydrocephalus. Lung ultrasounds, we have discussed just now. Abdominal ultrasound to look for the free fluid. And for neck also, it is being very well used for bladder size and aspirations. And then the line positioning. So, you can use probe where and whenever it is possible. So probe can be helpful for you, but it is an adjunct for your clinical knowledge. It is not a replacement. Thank you very much. Hello.
Hello. So there's a question from Dr. J.P. Soni, sir, Senior Professor at Department of Pediatrics, SN Medical College. This question is to Dr. Tushar, sir. How to decide type of inotrope depending upon the SVC flow?
Tushar is not there. Okay, I will take this. Dr. Tushar is not there.
Okay, sir.
So, sir, basically, previously there was an era when we used to use SVC flow as a marker of cardiac output, but now it's a kind of obsolete thing because there is a great intra-observer and inter-observer variability. So that's why now we don't only depend upon SVC. So previously it was many papers they were published regarding dobutamine, dopamine, depending upon the SVC flow. But the best would be you see the cardiac outputs, okay, afterload, preload, and the cardiac functions. Need to know the etiology. And then, like, if you know the blood pressures and you know the cardiac outputs, whether you calculate the cardiac output through SVC or from the left ventricle output, from the Dopplers of the aorta. If you calculate, suppose your cardiac outputs are low, your blood pressure is high, cardiac functions are good. So that means your afterload is high. So it means you need to give inodilator, like drugs like dobutamine or milrinone, and you should not start adrenaline or dopamine. And if your cardiac output is high, okay, your blood pressure is low, cardiac output is also is high output failure, like in sepsis. So then you have to use a mixture of inotropes like dopamine and dobutamine both. So that's how clinically and echo-wise we decide which inotrope we need to use. Any other question?
Thank you, sir. Sir, Department of Pediatrics, Dr. SN Medical College, Jodhpur is doing marvelous work in the field of this point of care of ultrasonogram. And Dr. J.P. Soni, sir, he texted this thing. In 96, they gave ventricular index for preterm and term neonates for Indian neonates in Indian pediatrics. In 96, they published article for ICH in neonates with complications in Indian pediatrics. And we in Rajasthan at Jodhpur, we are using ultrasound in newborn from 93, in particular cranial USG. In 93, one of the radiology candidate did a thesis under his supervision, and he was his co-guide. And Dr. J. Prakash Soni, this thesis was on cranial USG in neonates and babies up to 18 months. And he also gave lateral ventricle index norms for preterm and term neonates in Indian pediatrics. So they are doing a lot of neonatal echo at the echo lab at SN Medical College, Jodhpur. And they have 3 theses on neonates on functional echo, and one on PDA publication in pediatrics. This was the message from Dr. JP Soni sir, that they are doing
Great.
marvelous work
Yes,
in
sir.
focus.
Yeah, we know that, sir, and we are very grateful for your work in this regards. In like you started this thing when I joined MBBS, so it means your experience is vast. Thank you very much, sir, for this. Anything else?
Pradeep sir,
Should we close the workshop?
Pradeep sir, are you here?
Don't know if he's busy somewhere.
Anurag sir?
Okay. No, nobody is there.
Neeraj sir?
Dr. Pradeep, I'll request Dr. Pradeep to give the final remarks for the day. Dr. Pradeep? Hello? I think...
Let me call him. Just a second.
Just a moment. Dr. Pradeep is just joining. Dr. Anurag sir आ गए हैं. Anurag sir?
Yeah, hello, good evening. I'm there now. So, I think you guys have concluded, Mohit?
Yes, sir.
Okay, so I was there for most of the time, and this was the most heavily attended workshop. So when I was in the initial part, in the first 10-15 minutes only, more than 50 people had joined, and they were keeping on coming for this point of care workshop. I was through for the initial sections where Dr. Mohit had explained all the views, the subcostal, the long, short, and then he went on to tell us about the fish mouth and the crab view and all the other views. So, and the ease with which all of them were being told. So that was something remarkable. And the way you had prepared your slides to show the apple in the cross section and the cut section and the coronal and sagittal, that you correlated with that, along with the 3D diagram that you prepared, that shows that how deeply you are involved into teaching. And that is one reason why it made so easy. The concept became so easy for everybody to understand, because you had simplified it by your deep preparation, the preparation that you made in preparing your slides. And going on from there, when we saw the intraventricular hemorrhage, there was something new to learn for me also. My thesis 30 years back was on ultrasound in pyogenic meningitis, and the radiology people had reported bilateral brain abscess to the ventricles. So that is where we started 30 years back in Rajasthan, where ultrasound was there. But from there, we've come a very long way, where this tool is there in everybody's hands now, and people are doing. And I'm sure the pediatricians and the neonatologists they are doing much better ultrasound than the radiologist. I have no, two thoughts while I share this. And the point of care in the NICU, that is a very, very important tool. And I'm sure you went ahead and told us about the other, the IVH and the other extracranial things that you talked about. It was all wonderful. I just missed some 10-15 minutes in between because we were on a hop on, hop off flight tour between all the different workshops. But whatever 15-20 minutes I've missed today, I'll just come back and then I'll study that again, because this workshop has been so useful, so tremendously useful. And I'm sure it is going to change the practices. I'm sure people will pick up the probe now. Even if they don't have 8 to 12 megahertz, even if they have 5 to 7 megahertz, I'm sure they'll start using it and try to make some sense out of it. And this will help. And I think this workshop has been very, very useful. Thank you, Dr. Neeraj, for creating such wonderful workshops for us. And thank you, Dr. Pradeep, for allowing so many participants. I mean, it's just a surprise how you could do so many participants in a virtual platform. And I'm glad we are doing it on United Nations Day. So it's now India United.
So
So over to you guys.
The virtual but has always been better than a real word sometimes. So
Definitely.
So it was a wonderful workshop and very useful too. Basically, our exposure to sonography was because of one of our teacher, Dr. J.P. Soni. So much so that we were confused between sonography and Dr. Soni. We used to call it sonography sometimes. And I think Dr. Soni sir is still around. He is one of the audience as of now. And in his chat box, he has written some work he has done. And
Yes.
that was when we were doing MD even. I mean, it was as early as 94 to 97. And in the chat box, you can see Dr. Soni has written papers and he is doing a lot of work since 96 onwards. So it's because of that great man that we have good exposure, even early residency times to sonography and echo. So he always helps us around making right diagnosis and all those. But now it has gradually becoming very more frequently used practice, and gradually I think a lot of things depend on sonography, and what we call as focus these days, right from interventions to diagnosis to management of shock to anything, any damn thing. And we have come from era of senior clinicians dictating the terms to evidence-based medicine because of these techniques. I think they are very useful, and more pediatricians and neurologists should use it in their day-to-day practice, and should, because it will become a clinical examination. After your standard of inspection, palpation, percussion, auscultation, looking through sound is very important. I congratulate you all for a wonderful session. With Tony, always you have make us learn new things, and you have been really thankful to you.
Thank you very much. Sure, sir. Thank you very much for arranging this and having with you. So have a great day, sir. Everybody, thank you very much for being here. Thank you, Neeraj. Thank you, Pradeep sir. Thank you, Anurag sir.
Thank you, Mohit sir, for a wonderful workshop. Thank you so much.
Thank you. Thank you.